Hello, I'm Dr. Ronnie Weathers. On behalf of Emory University School of Medicine, the Department of Continuing Medical and Dental Education, we are pleased to offer you this course on radiation safety and radiographic interpretation for the dental auxiliary. Upon completion of this course, the dental auxiliary will be in compliance with the regulations set forth by the Georgia Department of Human Resources Radiologic Division. The goal of Emory's continuing dental education program is to provide the practicing dentist with the latest scientific and clinical information so that this can be translated by the dentist and his staff into the best possible care for your patients. We hope that this program will meet your expectations as well as ours. Thank you. I am pleased to introduce to you the course presenter, Dr. Dale A. Miles. Dr. Miles is Associate Dean for Clinical Affairs and Professor of Oral and Maxillofacial Radiology at the Arizona School of Dentistry and Oral Health. He is a diplomate of the American Board of Oral and Maxillofacial Radiology and the American Board of Oral Medicine. He has been a test construction consultant for the National Dental Examining Board for the ADA and on occasion serves as consultant to the FDA on radiological devices. Dr. Miles is a featured CE speaker for digital radiology and for teaching PowerPoint in the American Dental Association seminar series. He has authored over 125 scientific articles and 4 textbooks and has given over 300 invited presentations nationally and internationally. Dr. Miles serves on the boards of Visionary Technologies and Advanced Dental Imaging, Nevada corporations involved in image software and image interpretation.
Hello, my name is Dr. Dale Miles. I'm Associate Dean at the Arizona School of Dentistry and Oral Health. I'm here today in Emory's Continuing Dental Education program to present material on radiation safety and radiographic imaging for dental auxiliaries. We have a lot of content to cover today. We got to talk about radiation physics, radiation biology, radiation safety and protection, and quality assurance. It's important to understand just how X-rays interact with patients and to have safety measures in place to prevent the operator and the patient from unnecessary exposure. Radiation physics is a very dry subject, but it didn't always start out like that. The history of X-rays is quite interesting. We don't have a lot of time to go over that material today, but it's a wonderful sort of story if you get to read about the inventor or the discoverer of X-rays. The X-ray was discovered by Wilhelm Conrad Röntgen. Röntgen was a physics student studying in Austria and was working in his laboratory. He had a setup where he had a cathode tube, actually called a Crookes-Hittorf tube, in which he was running currents from a cathode to an anode. We will see these parts a little bit later when we study the actual X-ray generator. On November the 8th, 1895, he actually saw a screen placed at some distance from his tube, which was completely covered in black paper, glow. This phosphor in the screen glowed, and he wondered how that happened. In December that same year, he actually juxtaposed his wife's hand between the X-ray device that he was attempting to experiment with and another screen phosphor material. And his wife, Bertha, had a radiograph of her hand taken. He didn't know what to call these X-rays, and so he termed them an X-ray. And there's quite a good piece of history that you can read if you go onto a website called nobel.se. It's the Nobel Prize E-Museum, and you can read about a lot of Röntgen's work on that particular website. Röntgen himself worked with a tube from some of the other people at the time working with high voltage electricity called a Crookes-Hittorf vacuum tube. Excuse me. In that tube, there was both a cathode and an anode. And when you ran a current through the cathode, there would be little electrons boiled off. They didn't know what they would do inside the tube at the time. But electrons were boiled off at the cathode and sped across to strike the anode and produce these X-rays. And we will see much more of this a little bit later. Excuse me again. This discharge tube, when activated, made the following image of Bertha's hand. You can see bone structure, some soft tissue, and you can actually see her wedding ring on this particular image right here. For that particular invention or discovery, Röntgen won the Nobel Prize in 1901. So the discovery of the X-ray was really in 1895 on November 8th. The awarding of the Nobel Prize was sometime later after Röntgen presented these findings to his peers. There are a lot of other radiology pioneers, especially in dentistry, and so we're going to cover just a little bit of that right now. In 1913, William David Coolidge designed a hot cathode high vacuum electrical discharge tube, quite a mouthful. And this tube made it a lot easier to produce X-rays and kept the tube generation sort of controllable. Other pioneers included Dr. Otto Walkhoff, who discovered and used the first dental radiograph as far back as 1895. Remember, that's only about a year after Röntgen discovered the X-ray. In the United States, there's some controversy or debate on whether it was actually a physician, William Morton in New York, or a dentist out of New Orleans named Dr. Edmund Kells, who actually produced the first dental radiograph in North America or the United States. Edmund Kells is a very sad story, unfortunately. Initially, a lot of these pioneers held the actual radiographic plate inside the patient's mouth while the exposure was made. This, of course, allowed them or subjected them to a lot of X-radiation to their fingers. This, in turn, in Kells' case, led to an actual frank cancer in his hand, and he lost his finger. Then he had his wrist amputated, then his forearm, and eventually his shoulder, at which point Kells could no longer survive these wounds or this X-ray exposure, and he committed suicide. William Coolidge, the inventor of the Coolidge tube, introduced a tungsten target. And again, when we talk about the X-ray generator, we will see this tungsten target and why they've selected it to produce X-rays. A little known pioneer, at least for most of North America, is Howard Riley Raper. He was an instructor at Indiana University, and he was actually the first instructor or the first dentist to write a textbook in dental radiology, including technique and interpretation. He also was the inventor of the bite wing tab, and as you know, and many of us have used the bite wing tab, it's been a product that has widespread adoption in the world. He sold the rights to that bite wing tab, the patent, to Eastman Kodak in the 1930s, the late 1930s, for $1. In return for a 10% royalty on every bite wing tab sold in perpetuity after that. And the Howard Raper Fund at that university is significant to this day. X-rays have very interesting properties, and these properties allow them to penetrate tissues and expose the image receptor, whether it's film, phosphor plate, or charge coupled device or solid state detector. They travel very quickly, 186,000 miles per second, in straight lines, just like light. They are invisible, however, so we cannot see them. We can see the results of the X-ray penetrating tissue and receptors, but we cannot actually see them themselves. They can penetrate materials, as we said, which is why we wear protective gear, like the patient that you see wearing the thyroid collar here in the image. And they're like other electromagnetic radiation, like ultraviolet waves, like infrared light signals. They are traveling in straight lines, but they do not get affected by magnetic fields. They are absorbed differentially in materials and tissues, which is why we can use X-rays to penetrate patients, but if a larger patient is present in your chair, it will take more time or more X-ray exposure in order to make that image. They also cause ionization, and we're going to talk about more of that later when we talk about the biological effects of radiation. Ionization is a very, very prevalent process in the human body. It actually occurs when X-rays strike water in the body, of which we're mostly made up of water, and produce basically things called free radicals, and we'll talk about more of that later. X-rays basically come into tissues in the following way, and there's some important interactions with X-rays and the electrons within an atom of the human body or of a structure. In the middle of this diagram, you can see a nucleus, excuse me, a nucleus, and here's the nucleus with some protons and some neutrons. Balancing that, of course, are the electrons in the inner and outer shells of the atomic structure. If we look at this more complex atom, we can see that there's a neutron, a proton, some electrons circulating around in things called orbits around the center or the nucleus. We have different energy shells in these particular atoms of structures. K, L, and M are some of the shells that exist. The most important interactions of X-rays with atomic structure of the patient or the receptor are with the K shell sort of orbit. And the further from the nucleus that an electron is, the lower what's called the binding energy. So there's more energy in an inner shell electron than there is in an outer shell electron. And it takes more energy to displace these when an X-ray has an interaction with them. So this one kind of feels a little weak way out here because he's much further from the nucleus. So to reiterate, the most important X-ray interactions occur with K-shell electrons, and we're going to study a few of those right now. In order to eject an electron from the orbit of an atom, there's a thing called binding energy, and it's measured in electron volts, or EV. And electron volts, the binding energy, is the minimum energy that must be applied to eject an electron from a K-shell. The closer the nucleus is, or the electron rather is to the nucleus, the higher the binding energy. So sometimes it takes quite a significant force to eject an electron from the actual atom. We'll watch a little animation here of what happens when an X-ray photon interacts with an atom and the K-shell. If an X-ray speeds in and strikes a K-shell electron, there's a minimum binding energy that it exceeds. That actual electron will be ejected from its orbit near the nucleus. The electron was first described by J.J. Thomson in 1897. X-rays are electromagnetic radiation, part of the electromagnetic spectrum, kind of like visible light. Although they have a much shorter wavelength, you can see down here that X-rays in this particular spectrum are around 0.1 nanometers. A nanometer is a billionth of a meter. Visible light, of course, is up in the 500, 600, 700 nanometer range. So you can tell that the X-rays are a whole order of magnitude smaller, in fact several orders of magnitude smaller than actual visible light. All electromagnetic radiation have properties, including X-rays. Some of these we saw earlier, and we'll just reiterate a few of these right now. X-rays have no weight. They are not particles, although they travel like particles through space and through the patient. They travel at the speed of light, 186,000 miles per second. They have no charge. They travel in straight lines, and they're not affected by a magnetic field. However, they do propagate their own magnetic field as they travel through space, through the patient, and through the body. They have their own energy, frequency, and wavelength, which we'll discuss in a minute, which is how they can sort of selectively penetrate, depending on their energy, through different parts of the human body. And although, again, we don't think of them as particles, we also don't think of them as waves, but they travel with a wave-like motion. If we look at this diagram, we see sort of a wave pattern. You can see from peak to peak, this is one wavelength, and the X-ray basically travels along this kind of wave pattern through the body and through space. This would be a highly energetic X-ray because you can see a short wavelength there, and it travels and penetrates tissues quite readily. If we put that in perspective in a clinical format, if you had, let's say, very low energy X-rays, 30 kV X-rays, these would not penetrate the patient very readily. They would actually enter the patient and then stop and impart most of their energy to the patient. That, of course, would cause some radiation damage. So if you have a long wavelength, low frequency X-ray photon traveling through the body, it will take its time and it will stop and impart damage because it doesn't have the capability of actually penetrating directly through the patient. Whereas if you have a shorter wavelength, high frequency X-ray photon, such as you see with 70 kV X-rays, the range that we do our clinical dental radiography. And then those 70 kV X-rays actually are much speedier and much more penetrating and can pass through the body more readily. So despite the fact that we X-ray our patients, not all X-rays stay within the patient. In fact, most travel through the patient and do not cause any damage. The properties that we'd like to think about for this X-ray that we use in dentistry is the shorter the wavelength, the higher the energy. For instance, a 90 kV X-ray would have even more energy than a 70, but most of our machines these days are actually limited to 70 kV. These X-rays give high contrast and make for better sort of bite wing caries detection radiographic images. But the shorter the wavelength and the higher the energy, the greater the penetration. Again, if it has less penetration, like something in mammography at 40 kV, it's actually going to stop more in the tissue. So it's actually better in our case to use higher energy X-ray photons. The types of radiation we have to consider when we're looking at interactions with the human body are characteristic, photoelectric, and a thing called the Compton effect. And we'll see some of those interactions in some animations. If we have this stylistic cartoon of our atom again with different electrons in different shells, if an X-ray photon speeds in, it will eject an inner K-shell electron. That K-shell electron will leave that orbit, but the actual atom will become unstable because it left the orbit. So an electron in let's say an outer shell, the large blue one that we see on the screen, might drop into the actual area left by the inner shell electron. When that happens, it has to give up some energy to do that, and that energy is called characteristic radiation. Characteristic radiation is what we use in an X-ray tube generator to select the anode or the target to actually give up X-ray photons of a certain energy, let's say the 70 kV X-rays that we need to actually make dental radiographs. These effects, however, also occur in the patient's tissues. In the next slide, we will see the photoelectric effect.
In the photoelectric effect, an X-ray photon collides with an inner shell electron. This collision ejects a recoil electron. An outer shell electron falls inward to replace the ejected electron. As it does this, lower energy radiation called characteristic radiation is released.
This photoelectric effect is quite prominent in X-ray interactions within the patient, and X-ray photons undergoing this effect actually add to the patient's dose. In the next slide, we will see another effect.
In the Compton effect, a high-speed X-ray photon collides with an outer shell electron, ejecting the recoil electron. Some of the energy is imparted to the recoil electron. The rest is released at a lower energy.
The lower energy that is actually escaping from the ejected electron shell will actually add again to the patient's dose. Compton effect and photoelectric effect are the two most common interactions of X-rays in the body. The photoelectric effect is the primary cause of what we call ionization. Ionization is the dissociation of water primarily in the human body into molecules. These molecules can interact with others, and the effects caused on the human body are called direct effects. Some of these include breaking a molecule into smaller parts, forming a new bond with another molecule, forming a bond between two molecules, or disrupting a molecular bond. When these effects occur, which are quite rare, they can impart damage directly into the human body. Unlike the photoelectric effect, the Compton effect occurs with an outer shell electron, so that not all the energy is imparted to the recoil electron. This energy that's left over can actually be absorbed into the human body. It can cause ionization as well, and what we call scatter radiation. Scatter radiation primarily degrades the image because it's low energy X-ray photons that add no usefulness to the X-ray image, and it also contributes to an added patient dose. So we want to reduce this scatter radiation as much as possible. We now move on to the molecular effects of radiation on the body. We already talked a little bit about the direct effects called photoelectric and Compton, and we saw some of those interactions. Now we want to talk about indirect effects, what we were talking about as we termed it ionization. When water dissociates in the human body, there are free radicals formed, and these free radicals can cause tremendous deleterious effects to the human body. X-rays are not the only source of free radicals. In fact, interactions with our environment can produce many more sort of free radical formation than actual X-rays. We're not X-rayed every day, but we actually carry on human life every day so that we have these interactions on a routine basis. And we'll talk about these tissue effects again a little bit later and how they're repaired, especially when the damage from X-rays is produced. We'll talk about how rapidly it's repaired in most humans. The next section we're going to talk about is X-ray production and X-ray generators. This, of course, is the device you use to make the radiographs in the office. The operator produces images on X-ray film, on photostimulable phosphor plates, or on the current solid-state detectors. And we'll talk about those receptors later on today. There are components of the X-ray tube that you need to understand. The X-ray tube head, as seen in the top picture, is the thing or the device, the machine that you use to produce the radiographs. However, we have to set some controls on the control panel, the bottom image, and these controls include the kilovoltage, the milliamperage, and the time. We cannot, in most machines these days, actually alter the kilovoltage or kilovoltage. We cannot, in most machines, alter the milliamperage. This is fixed usually at 7 to 10 mA. What we can do is alter the time. And in some machines, you can actually have a lookup table or an icon on the control box for a premolar view or molar view or a child or adult setting. The radiograph, when it's produced, should have the clarity and the image resolution, the density and contrast that you see on the image on the right. Inside the X-ray tube, in order to produce this image, are components called the anode, the cathode, the focusing cup, the target, and the focal spot, and we'll discuss those each individually. On the left side of this diagram is a schematic of an X-ray generator tube head. On the right is a diagram of what would be contained inside that tube head. You can see an area labeled cathode, and in that cathode region you can see a small curled wired filament. This filament is where the MA or the milliamperage circuit is run, and in this area electrons are boiled off or created and held by a charge in that area. Electrons are charged negatively, with the cathode being also charged negatively. So they stay in that region until we actually activate the exposure timer, at which point they speed across to the area labeled anode and strike a area in the anode called the target. The target is actually made of tungsten. The surrounding area in a gray color is made of copper. Copper is good at dissipating the heat, which is produced when electrons speed across and strike that target. A lot of the X-rays that are produced at the target, they go off in 360 degrees, and a lot of them do not exit the actual X-ray tube. The lowest arrow that you see on the diagram describing X-rays exiting the tube is actually called the port, and the beam is collimated there to allow only a few X-rays to actually exit the tube. The anode, as I described earlier, is primarily made of tungsten, and the reason it is because tungsten has when electrons bombard the tungsten target, they produce a characteristic radiation in the range of diagnostic radiology. So there's actually a characteristic radiation interaction at the anode target. The anode is charged positively, and the interesting part is that even though X-rays are produced in the tube head and go off in 360 degrees, only about 1% of all of the electrons striking the target result in X-ray production. So only 1% of all the X-rays that are produced there actually exit the tube. The remainder of that particular energy that is produced there is heat, and the heat is absorbed primarily by oil in the tube head, and we'll see a diagram of that in a minute. The cathode is actually charged negatively, and this is again where the electrons are, quote, boiled off from the filament circuit. We've seen that earlier. The filament is a small wire that's wound around a core, a copper core, to form a transformer. And the wire, when it heated up, actually releases these electrons, which, when the tube current is turned on, speed across and strike the anode. There's also an area called the focusing cup related to the cathode, and this is what I tried to describe earlier, where the electrons are held in a very tight cloud until the circuit is turned on, the timing circuit activated, and the electrons speed across. If we look at this diagram, and I think I've put an animation in here for you, the electrons you can see as small yellow spheres near the filament, the little coiled filament in the cathode area. So they are held there, repelling each other and held in a little cloud until this area's, until the circuit is turned on. And the blue arrow that you saw speed across would actually be X-rays striking the target. Now you'll notice that the target is angled, and the target is angled because we want to have as small a focal spot, which is sort of the actual center of the beam or the area that produces the image quality. And the smaller the focal spot, the higher the resolution, or the higher the image quality is. So they angle that anode target, the tungsten target, at about 20 degrees. And in actual fact, the resulting effective focal spot is much smaller than the actual focal spot. So it might be a 1 millimeter target, but a 0.5 millimeter effective focal spot. You can see I've labeled an area oil to dissipate heat. Again, most of the X-rays that are produced in that particular tube head come off in 360 degrees and are absorbed by the leaded tube head and the oil within that leaded tube head. So only 1% of those X-rays actually exit the X-ray tube. The actual X-ray tube is surrounded by glass, and this glass tube helps to keep the environment inside the tube head as a vacuum. The vacuum is the only environment in which the X-rays can be produced. So the tube is also filled with the oil within this glass tube in a vacuum environment. And again, just to remind you, as I did before, only 1% of all of these X-rays exiting the tube end up as diagnostic X-rays. If we examine the glass envelope diagram seen here with the oil, I'll give you another animation to show you how the electrons interact with the target to produce the X-rays. You can see a small set of white spheres representing electrons at the cathode, some of which will speed across and strike the target. Others will speed across, strike the target, and come off in different directions. And so they interact not with the patient yet because they haven't exited the tube, but within the oil and within that vacuum glass environment. 1% of those actually exit the tube and come out to produce the actual diagnostic X-ray. We described earlier the focal spot. This is just a simplified diagram to describe it a little bit more precisely. The target, I've labeled it here as 3 millimeters, which would actually be a very excessively large target, but because it's angled, could create a 1 millimeter focal spot. Another reason they angle this target is to dissipate the heat on that target material to extend the life of the tube head. So they can get a better image quality by having a smaller effective focal spot, but by angling the target, it can help dissipate the heat. Well, that ends our first section, and we're going to move on to the actual interactions of these X-rays in the body, in the human body. And we're going to call this section radiation biology. We have to deal with units of measurement, X-ray interactions with matter, biologic responses to X-rays, and some of the somatic and genetic effects.
In 1985, the International System of Measuring X-ray Dose was instituted. The old units, Röntgen, Rad, and Rem, have now become coulombs per kilogram, grays, and sieverts. The conversion is shown in this table.
We have to remember that it is the responsibility of the dentist or the clinician to inform the patient of these risks, and yet also describe to them the benefits from exposures to these diagnostic levels of radiation. Unfortunately, it's not an easy task, and I'll have some actual assistance for you later in terms of radiation risk and comparable risks that we take every day. One of the ways of estimating or calculating risk is to use something called the effective dose equivalent. And in medicine, whole body radiation is the standard, where they try and collimate to a particular body part, but they actually, in some cases, are radiographing or X-raying large body parts. We deal with just the head and neck region, and so we're dealing with a much smaller area of the body, and we collimate our beam much more precisely. The effective dose equivalent, if we could look at this table and compare it to medical radiology, we'll put it in terms of the background radiation equivalent time. So you'll see a column called BRET, background radiation equivalent time. This is equivalent to just natural exposure in the daytime environment to sun and cosmic rays and other things like radon. So you can see that a dental X-ray procedure, maybe was a single film, a single periapical or a single bite wing film, has the equivalent of about 1 to 2 millirem. Remember, milli means 1,000th of a rem. So this is a very small dose. Chest film, by comparison, is around 5 millirem. The skull, when you're radiographing for cephalometric radiology or orthodontic type images, is around 10 to 20 millirem. So these doses are quite low. And you can see that an area of the pelvis, which is a larger area being examined for, in men, prostate cancer, and women for ovarian or whatever the procedure's for, is actually quite a bit larger exposure dose to the patient, somewhere around 100 millirem. In head and neck CT, because they move the patient through the machine taking multiple slices in 360 degrees, you can see that the effective dose equivalent in millirem is closer to around 300 to 400 millirem. So these are significant doses. Now, X-radiation by medical personnel or dental personnel is not the only radiation that we're exposed to. If we look at the column on the left called the source, you can see that even in the natural sort of environment that we live in every day, we are being bombarded by cosmic rays, and the dose is around 0.27 millisieverts. Again, these are relatively equivalent to the previous dose measurement, the grays, or millirems, but this millisievert from cosmic ray is about 1/3 of what we saw from a dental radiograph just by walking around in the environment. You can add to that X-radiation from rocks around us, and it's really not X-radiation, it's just radiation, probably gamma from the decay of different products in the earth, and you can see that also adds some dose on a daily basis. Internal sources, foods we ingest, air we breathe. Air contains radon in the air, in many areas of the country higher than others. You can see that there's a much larger sort of component of the annual effective dose, around 2 millisieverts, from just radon in the environment. So on an annual basis, we would probably receive around 3 millisieverts of dose to the human body. Medical and dental is much less than that, primarily because not every day are we X-rayed in a procedure by either a medical procedure or a dental procedure. So it's around 1/3 of a millisievert, or 0.39, but it is still the largest component of man-made radiation. So we need to try and reduce this risk as much as we can, and we will see measures to do that in a minute in our next section. To break the information down a little bit differently and put it in kind of a pie chart arrangement, you can see that cosmic rays, for instance, add about 8% of our annual dose to our bodies. Terrestrial, including the rocks, as I said earlier, and even building materials, another 8%. Internal sort of product ingestion and X information or radiation that gets into your body, around 11%, which is equivalent to medical and dental. And by far the largest risk and the largest exposure we have to radiation is actually by radon in the air. If we wanted to put that in perspective in terms of the receptors that we use in dentistry and how we can reduce this dose or this risk from the dose, currently D-speed film has actually been, it was the standard up until very recently. E-speed film, you can see in the middle row, has actually been discontinued by the largest manufacturer, Eastman Kodak. But you can see a very significant reduction in the dose, either in rads or milligrays to the patient, when you move to faster films. From D to E reduced the exposure by half, and that's what the vendors told us. They said you will use 50% less time in order to make this exposure, therefore you're going to give the patient 50% less dose. As you move down the column, you'll see that the charge-coupled device, and I know a lot of you aren't familiar with that terminology, but it's one of the solid-state detectors, one of the types of little electronic sensors we place in the mouth of the patient these days, is another significant reduction in exposure dose. You can see that the dose is around 40, and that should be millirads, or 0.04 milligray to the patient. So it's a very, very significant reduction, and I think it behooves us all to think about moving on to these newer imaging receptors. Photostimulable phosphors, in actual fact, their exposure time lies somewhere between the exposure time for E-speed film and charge-coupled devices or solid-state detectors. So they might be possibly about 40% less than an E-speed film dose. Now, having looked at those doses and knowing the receptors and what they produce, let's move on to the molecular biology and let's talk about this ionization. To review, when water dissociates in the body because of X-ray interaction, you have the following things occur, or possibly occurring: breaking of molecules into smaller parts, forming new bonds with other molecules, forming bonds between molecules, or disrupting a molecular bond. These effects from ionization are significant because they can cause damage within the human body. We discussed earlier scatter radiation, and scatter radiation is produced by the primary interaction of X-rays with the tissues, and it only adds dose to the human body because these X-rays are at a lower energy and tend to be totally absorbed into the tissues and not pass through them. Indirect effects of ionization are primarily the production of free radicals. We mentioned this earlier. We're going to look at it a little more closely now. Most of the human body, as we said, is made up of water. When these X-rays collide, they produce the free radicals, which are highly unstable. So they want to reconfigure and bind with other molecules to become stable. So they will affect enzymes. They can also affect cellular damage from enzymes, new enzymes they create. And so these free radicals can cause tremendous molecular damage within the body. When water dissociates to form these free radicals, they are formed as things such as hydrogen peroxide, hydroxyl, and peroxyl radicals. And these are termed cellular poisons. And most of the effects that are caused by X-ray interactions occur through free radical formation and then reconfiguration into other molecules. In the next screen, we'll see how some of these free radicals are formed.
If an X-ray photon interacts with water and oxygen, compounds called free radicals are formed. A free radical readily reacts with other biologic molecules. Examples are shown here. The effects caused by the radicals are not directly the result of the molecule being hit by radiation. Because the damage is mediated by a free radical, it is referred to as an indirect effect of radiation.
This alteration of molecules caused by the free radical formation is termed an indirect action. So again, to reiterate, indirect actions primarily occur by ionization of water into free radicals. Direct X-ray interactions can break molecular bonds and affect molecules in a more direct manner. We'll see that on the next slide as well.
Although the odds are astronomical, an X-ray photon could strike a strand of DNA. It might break a molecular bond between the two strands. This broken bond would be incorporated into the new cell and carried on for generations of cells after that.
So to summarize, radiation damage to DNA may lead to changes in the base sequences. This could result in defective protein synthesis and unusual cell proliferation. These do occur spontaneously, but radiation increases that frequency. Now, it's important to know that this cell repair is actually going on at the same time as cell damage. So in some cases, damage from X-rays or other things in our body, things we ingest, is actually repaired very rapidly in most humans. It occurs more commonly and quicker in younger individuals, and as we age in a process we call immunosenescence, sometimes these effects are repaired or in a much slower fashion or not repaired at all, and leave us more prone to things like cancers later on in life. There is a difference in the cellular sensitivity of the different cells in our body. If a cell like epithelium of the skin or the cornea of the eye has a high mitotic rate or divides frequently, this will have an increased cellular sensitivity. In fact, if a cell line has a long division future or mitotic future, this also will make it more sensitive to X radiation because of the numbers of generations that could be exposed. They are also more sensitive if they're more primitive or less specialized. So the thing that's in the news these days are stem cells. Stem cells would have a higher cellular sensitivity. The most sensitive cell is the actual lymphocyte. I've put here a list of some of the cell types that occur in the body, with the most sensitive being at the top, being the small lymphocytes as mentioned, followed by things like bone marrow, intestinal mucosa, skin, the oral mucosa, which is kind of a moderate radiosensitivity, on down to muscle or nerve, which are highly radioinsensitive. And it's important to know that children's tissues, no matter where they are far more sensitive. For instance, the thyroid gland is developing and very sensitive to X radiation. However, thyroid tumors have a long latent period and don't occur for 20, 30, or 40 years later, so that we will have gone through a lot of other deleterious effects and things on our body. So it's very difficult to say that X-rays could cause a thyroid cancer. However, it behooves us to take all the protection measures necessary in order to reduce children's exposure to X-rays. Now, if you ask the average patient, what causes cancer, commonly, especially in the dental office, the first response will be X-rays. And the reason for that is somewhat problematic because there's all kinds of press around the world. Here's a Time magazine from the late 80s, before the fall of the Berlin Wall, and they were protesting nuclear proliferation. And we see these sort of articles about how damaging X-rays can be. Of course, we take all the precautions, as do our medical colleagues, in order to reduce this exposure or the amount of dose that the patient gets, and we're going to see how we do that in the next few slides. We've made tremendous strides in the last 2 to 3 decades in reducing patient dose. The image on the left is a very interesting image. It was the introduction of the long cone technique on a child, and they're trying to say how much safer this long cone technique was. But if you'll notice, the child is holding the image receptor. There is no thyroid collar, nor is there a lead apron. And this was an actual image out of a textbook in the 70s showing this new technique and how safe it was. Of course, we would not do that today. In the image on the right, the patient is shown with a image receptor holder, fixed to the receptor. The film is inside the patient's mouth, of course. The patient is biting on a bite block. And we've actually used a ring device on a metal rod to directly point that cylinder from the X-ray tube head precisely at the target or the image receptor inside the mouth. And of course, the patient is not only wearing the thyroid collar seen here, she would also be using a leaded apron. There is a new report that we'll discuss later that will show some significant changes to this protective gear that the patient is now wearing. So we've made great progress, but we've got lots of things that we can do to reduce the patient's exposure. One thing that we can do is educate our patient, and once we've asked them what causes cancer and they say X-rays, we can also say, well, the things that we do in our environment every day put us at risk of causing cancer, and I'm going to discuss equivalent risks. We all know that quite commonly skin cancer occurs, melanoma on the face, basal cell carcinomas in the upper half of the face. And here on this patient's lip, we can see the effects of sun damage. You can see some scaled patches on the lower lip, and these could be premalignant changes due to the actinic damage of sun. Well, we're certainly not going to avoid the sun. We will do things like putting on protective UV balm on our lips, wearing headgear on our heads, and sunscreen on our faces in order to minimize this damage from the sun. But the sun, as you recall, is just electromagnetic radiation in a light form and can cause significant damage. So we're going to talk about some of these things that cause cancer and the equivalent risks. So sun causes cancer. Here are the protective measures that we would take. You can see this actual Indiana dentist who posed for this picture with a hat on his head, sunglasses to protect the corneal areas and the sclera of the eye, putting on lip balm on his lips every hour to prevent them from having the damage seen on the left. And of course, he'd be wearing sunscreen as well. This patient on the left has a lesion, a large lesion near her left eye, and you can see quite a significant size to that lesion. This is a basal cell carcinoma. This is quite proliferative. Luckily for this woman, this particular cancer is locally invasive but rarely metastasizes, and it almost always occurs on the upper half of the face. This was produced not by X-rays but by continued exposure to the sun. She was in her youth, of course, fair-skinned, blonde hair, and blue-eyed. We also have risks that we take just by normal daily life routine. When we ingest food, some of these foods can have pesticides and other agents that can cause production of free radicals and cause problems. In this table, we can see pesticides, crops, and hazards by the pesticides residing on some of the products that we eat. And of course, if you look in the middle column, you can see there's a lot of things that you and I both eat in there, grapes and peaches and cabbage and things that are good for us. But on the left-hand side, you can see that many of these have been sprayed with pesticides in order to produce a bigger harvest and have a more robust sort of product. But if you look at the column on the right, there are not necessarily cancers in all cases, but certain pesticides have been related through good science to damage to the human body, including cancers or birth defects or things like central nervous system effects. So we have to be careful, and we have to wash our foods and do the things that we need to do. However, we're not going to give up eating these particular products. There's also dangers in the air. I'm not going to spend much time on this, but the effects from things in carpets and Xerox machines, some of the chemicals that are in Xerox copying machines can cause other things. And we certainly have a work environment where we try and minimize those, but we cannot give up those particular risks as well. And we all know infamous product called tobacco. Either smoking tobacco or smokeless tobacco or chewing tobacco can cause cancer. These are known entities. And we can see a huge lip cancer on the right from the effects of smoking. So that cancers related to smoking and drinking are very common, and people are not going to give those things up very easily. They're very habitual. So here's a snuff patch on the buccal mucosa, the lower right in this patient's mouth, and you can see the corrugated surface. This person will be very difficult because they enjoy that particular product and have a habit. This patient will be very difficult to change behavior in. Here's another snuff patch and some of the root caries associated with it because of the sugars in snuff. This poor woman I saw many years ago in San Antonio, one of my patients who came in with a huge tumor, again from dipping snuff. So that patients, even though they worry about our x-rays, they do other things on a routine basis that are much more risky and lead as a direct contribution to a cancer. Now, you may laugh at this, and when I show this, sex causes cancer, and of course we all kind of panic because I, for one, certainly am not going to give up this particular activity. But it's true. We have actually related increased sexual activity, various forms or methods of sex that can cause problems like the HIV virus problems and Kaposi's sarcoma, and studies of women with multiple partners contracting human papillomavirus, which we know certain types have been linked to cervical cancer. So, we are not going to give up these activities, food and fun in the sun and alcohol and tobacco and sex. We're just not going to give those up in most cases. Now, we said the patient worries about X-rays causing cancer. The actual paradox here is that X-rays not only cause cancer, that's a known fact in very high doses, certainly not the doses we use, but X-rays are also used to cure cancer. So you can have radiation therapy where the tumor is actually being bombarded with X radiation in order to cure it. Many times this is post-excisional biopsy or post-surgery, but X-rays are also used, as we know, to cure cancer. So in order to help you with your patients, I've developed a table from some data that has been published 1 or 2 times before, and these are activities that have equivalent risks to having a full-mouth series of radiographs. 18 to 20 full-mouth intraoral film-based or conventional radiographs. The risk of getting a cancer in the population is about 1 in 1 million, and that sounds quite high. But these equivalent risks, when you discuss them with the patient, maybe are actually much, much higher. For instance, if you live in Denver for 2 months, because you're higher up, it's around Mile High Stadium, you're being bombarded with cosmic rays at a much greater frequency and much higher intensity. So living in Denver every 2 months, you run the risk of contracting a cancer of some type with the same risk, 1 in a million, as a full-mouth series of radiographs. And you know that we're not all going to have a full-mouth series of radiographs every time we go to the dentist. We establish those at baseline, and then we move on to recall-type radiographic procedures. If you live in New York, this is not contracting a cancer, but if you live in New York or you visit New York, for every 2 days you spend there, your risk of dying from a mugging is 1 in a million. If you canoe, if you're healthy and get outdoors and do sporting activities, every 6 minutes that you spend in a canoe, you're at a risk of 1 in a million of drowning. Cyclists, very, very sort of hazardous activity. For every 10 miles a cyclist rides, the risk of dying in an accident with an automobile is 1 in a million. Riding in a car, certainly where I live in Phoenix, Arizona now, I probably put 400 miles a week just going back and forth to work. Well, my risk is 1 in a million for every 300 miles I drive. Drinking wine, certainly an activity I'm not going to give up. We have probably 1.5 bottles of wine each week between my wife and I. And drinking wine, if you drink a half a bottle, your risk is 1 in a million. These are things you can discuss with your patient if they do any of these activities to put them more at ease, to say, look, you're already taking these risks. Our X-rays are not anywhere near this risk, and we take all the precautions to reduce that risk that we can in this office. If you drink the water in Miami for a year because of the pesticides and the runoff in the water into their systems, you basically run the risk of contracting a cancer 1 in a million again. And smoking, it only takes a half a pack of cigarettes a day to make your risk 1 in a million of getting an oral or lung cancer. So this is a nice chart that you can discuss with your patients, especially those that do these activities, to put it in perspective and say, life is not without risk. We're taking all the things and doing all the things, taking all the precautions and doing all the things we can to reduce that risk. Now, if we want to get a little more specific, I will show you how the use of faster receptors and the use of collimation, for instance, from a round cone or cylinder to a rectangular device actually can reduce in the general population the number of excess cancers. This data was published many years ago by Dr. Stu White in California. If you have a 4-bite wing radiographic exam and you use a D-speed film with a round cylinder attached, the likelihood of producing cancers is in the neighborhood of 30 in our population in the United States. If you went to a faster receptor like E-film, which again we've said has now been abandoned, although it's been replaced by an even faster receptor called F-speed film, the reduction in the cancers is significant when you use E-speed film and a rectangular device. In actual fact, the newest report from the National Council on Radiation Protection is going to make some suggestions about using rectangular devices on our dental X-ray tube heads. So we as dentists can actually reduce the exposure even further. There are critical organs of the head and neck. In the head and neck region, about 13% of the bone marrow that resides in the body is found in the head and neck region, but only about 3% actually in the jaws, the maxilla and mandible. But other tissues in that region, of course, we talked about the thyroid and its radiosensitivity in children. There's bone marrow, as I just discussed, skin in the region, salivary gland tissue has a moderate radiosensitivity, and also it was thought in the past the lens of the eye. We now know that the lens of the eye is no longer considered a critical organ. We actually have a threshold dose of 200 rads, which is a hugely significant dose that it would take in one X-ray examination to produce a cataract or damage to the eye. So we've actually excluded that now. So thyroid, bone marrow, skin, and salivary gland are the primary critical organs in the head and neck region, bone marrow having much less sort of amount than in the rest of the body. The next section we're going to discuss is how you can protect your patient from or during these X-ray procedures from a significant X-ray absorbed dose. We're going to talk about general principles, the guidelines for prescribing called selection criteria, radiation protection methods, radiation monitoring, some of the legal aspects, and also the units of measurement. What we're trying to do is practice a principle called ALARA to keep our doses as low as reasonably achievable for all our patients. This is not only a dental concept, this is a medical concept. So by using protective devices, by prescribing radiographs only when necessary, we can actually improve or lessen the dose to our patients by using this principle. In this sort of approach, we have to look at equipment, we have to look at selection criteria or prescription of radiographs for the patient, and also our techniques. We won't be showing radiographic technique in this particular series, but we will discuss some of the measures used in radiographic technique to reduce patient dose. You have to remember that even though I've described the dose as being quite low and put it in perspective with other things that we do and risks we take every day, still every exposure to X radiation carries risk. Having dental X-rays, however, is not the only risky situation you'll be exposed to in your lifetime, as we've seen. But you have to remember that medical and dental radiographs are elective. The patient can refuse these. If they refuse them, you should document this in your chart and have the patient sign that they refuse the X-rays and the reasons for that. There are very few reasons for refusing X-rays because of their safety today.
Dentists must use every means of reducing the X-ray dose to their patients. This is called the ALARA principle. That is, to keep the dose to their patients as low as reasonably achievable.
If we look at the receptor types and the sample doses, we'd seen this earlier in our program. Again, I want to reiterate that moving towards the faster receptors like the phosphor plates or the solid state detectors are probably the way we should be directing our practices today. I mentioned earlier that there were some guidelines for prescribing X-ray images. This is called selection criteria, and it's actually been published several times in our literature throughout the country. The Journal of the American Dental Association published the findings of one of their councils, the Council on Dental Materials, actually published these selection criteria way back in 1989. Selection or criteria or prescription radiography really states that before you radiograph a patient, there must be a reason. You have to examine the patient, establish a reason, determine that taking a radiograph will actually have some benefit, will actually help you make a clinical decision before you actually make the radiographic exposure. The only exception possibly is the baseline radiography done on a new patient, but again, only after examination. You may take more radiographs at that initial visit to actually examine the patient carefully. After that, a lot of factors come into play in terms of what radiographs are required at recall visits. So we as dental professionals have to make every effort to minimize patient exposure, and one of the best ways, and probably the most important way, is to actually take only those radiographs that are medically necessary. Selection criteria was not something that the American Dental Association dreamed up. Medicine had done this probably 20 years ago, and then the Federal Food and Drug Administration charged the dental profession to get their experts together and actually come up with these selection criteria. The Academy of General Dentistry, the American Dental Association, the American Academy of Oral Maxillofacial Radiology, American Academy of Oral Medicine, American Academy of Pediatric Dentistry, and the American Academy of Periodontology, as well as the FDA, established a panel of experts in radiology to determine and create these selection criteria. These criteria are published in many radiographic textbooks and are available actually from your dental distributor through Eastman Kodak. You can actually get these criteria to post in your office, so I won't be going through those. But suffice it to say that they've been published not only by the American Dental Association, but also in the Department of Health and Human Services literature way back in 1987. More recently, the Council on Scientific Affairs for the American Dental Association published a update or a report on the radiographic practices. But they reiterated that diagnostic radiography should only be used after clinical examination, and the routine use as part of a periodic exam is inappropriate. This has been published in JADA in February 2001. In addition, a more recent study in 1995 looked at the efficacy of these guidelines and found that the use of these guidelines as established by our profession and the FDA actually resulted in a 43% reduction of the number of periapical radiographs ordered, which are quite common in our practices, without missing, quote, clinically significant disease. If we look at this bite wing radiograph of a child entering the mixed dentition stage, you can see a tremendous number of large carious lesions on the primary molar teeth. If this patient is in their initial visit, of course you would want to take additional radiographs to look at the periapices of these teeth. In addition, you would have to take probably more frequent radiographs at frequent intervals until these disease processes were under control. On the other hand, if this was the bite wing radiograph taken at the child's first visit, you can see that there's no evidence of interproximal or occlusal decay. The patient has some primate spacing, and so it would be probably inappropriate to take periapical radiographs to supplement this examination. However, you would still want to take periodic radiographs on this child depending on their oral hygiene habits, their diet, and other factors. I don't want to leave you with the impression that we don't need to take radiographs. Radiographs are a standard tool we use daily. We have to use them judiciously, but there's lots of reasons and indications for taking radiographs in our office. For instance, missing teeth in this case. If clinically you looked at this patient and you saw that there were missing teeth and no history of some of them being extracted, of course you would have to take either selected periapicals or in this case a panoramic radiograph in order to establish the position and the whereabouts of those teeth. But I want you to really think about what it is that you're doing before you actually push that button, examining the patient, establishing a reason for those radiographs, and taking only those radiographs that you found a clinical or historical reason for performing. And the expectation of the findings on those radiographs will then outweigh the risk of that radiograph. Let's now examine some radiation protective methods. Of course, we have lead aprons at our disposal in our offices. We also have different pieces of equipment like the collimator on our X-ray tube machine. And there has been the suggestion that certain patients, and rather certain personnel, should be wearing these radiation dosimeter badges. For the most part, we've abandoned these in dental schools and other institutions except for primary personnel who deal with X-radiation on a daily basis. So in your dental office, we'll be making some suggestions based on the new report findings from the NCRP, but this is my take on primarily on dosimetry routinely used in the dental office. Badges?
A badge. Badges? We don't need no stinking badges.
Now, there are ways to reduce patient exposure that we've taken over the last few decades and continue to do. For example, the use of faster receptors. E-speed film was to replace D, although E-speed film, as I said earlier, has been primarily abandoned as a film receptor. But F-speed film, which actually had a an exposure dose or exposure time 40% less than E has been introduced as a competitive receptor for some of the solid state detectors and phosphor plates. High kV technique, this used to be thought of in terms of going between 70 and 90 kV techniques as a way of reducing exposure, using 90 kV in for some routine radiographic procedures. However, in this day and age, most machines are actually fixed or set at 70 kV because of the production of high contrast images at that kV for bite wing radiography. So manufacturers have tried to simplify the machine sort of characteristics to match our practices. Aluminum filtration or other types of filtration can be inherent in the tube head or can be added. And aluminum filtration is actually in the tube head to remove some of the lower end kV X-ray photons that only add to the patient dose and add nothing to the useful image. Accurate timers, this is extremely important, especially with the faster receptors these days, because the exposure times, for instance, for a solid state detector like a CCD or charge coupled device is actually about 4/100ths to 6/100ths of a second, whereas with a film, that exposure time is in the order of maybe 0.32 seconds to half a second. So there's a whole order of magnitude of less exposure time used, and it requires very accurate digital timers. Some of us may have to look at our X-ray machines and think about actually changing those X-ray machines that we've had for 10, 15, 20 years to more current versions or contemporary versions. So contemporary machines will become, I think, more commonplace in the dental practices as we move forward to reduce our patient exposures. Of course, the leaded cones exist already, whether they're cylindrical or rectangular. Film holding devices should be used mandatorily in offices just because they help predict where the film is, hold it in place better, and make our life easier with our radiographic procedures. Lead aprons or leaded aprons, we'll talk a little bit more about that and the use or non-use or non-need for them in the near future. Thyroid collars have been introduced and should be mandatory and used on every child patient in your office. Quality processing, this is a whole area that we won't have, we'll discuss a little bit later on, but we won't have a lot of time to spend on quality assurance or quality processing. But these procedures, processing procedures in our office need to be very carefully monitored and checked. And of course, if you're using a digital receptor or a solid state detector, then you will not have to have the sort of quality processing and chemistry procedures that are required in your offices currently. And then, of course, the single most effective way of reducing the patient dose is the use of selection criteria, as we described earlier, or prescribing radiographs only when needed. So you're really going to look at the number, the type, and the frequency of the examination and the number of radiographs required to extract the information from the patient to help you make better clinical decisions. Here's where I wanted to discuss the first of the changes that are being suggested by the National Council on Radiation Protection. And this report is number 145, the very latest released in December 2003. Previously, we were using a report which was almost 20 years old. One of the biggest changes that you'll see is actually in adult patients. The recommendation, and there are shall statements and should statements, the shall are being much stronger. Their particular recommendation is that the use of leaded aprons on patients shall not be required if all of their other recommendations are followed. You would have to secure a copy of the report. I will only go over some of the major changes during this section and other sections, but there are some significant changes in this report, and it might behoove you to get a copy of it or at least be aware of what changes are in the report. Protective devices, continuing with the thyroid collars. This is a shall statement that we will use, or we shall use, thyroid collars on all children, and we should use it on adults when it doesn't interfere with an examination procedure. For instance, in a panoramic procedure, you may not or should not use a thyroid collar because the actual shield will be in the path of the beam and will allow or not allow a diagnostic radiograph. It'll actually stop some of the X-rays from actually reaching the film. So they could not or should not be used in adult panoramic procedures. You can see this diagram, or this picture of the patient that we showed earlier with the typical round cylinder, which they're going to suggest is going to be better done with a rectangular cone or device. And I just wanted to remind you that the technique, although we're not spending a lot of time on it, can actually minimize patient dose as well. If we pay close attention to positioning of the image receptor, no matter what type it is, if we have proper exposure factors so that we don't have to do retakes from errors in those two areas, or proper processing that we'll see a little bit later. If we can minimize the, quote, retake radiographs to our patients, will again significantly reduce the absorbed dose in the general population. All of these areas have to be considered in order to minimize the retakes. Now, there are lots of other ways to reduce X-ray exposure, and some of them we've discussed. I'm going to just add a couple here. The fastest film or receptor speed possible, the positioning of the instrument, and I would like to suggest that as we transition from film or conventional radiography to digital systems, because of the very significant reduction in exposure time, those will be one very, very effective way of reducing your patient's dose. The use of exposure times with those receptors is much shorter. This is kind of a reiteration of what we said earlier. But you'll notice that I made these suggestions many years ago, the use of rectangular collimation. We teach it in dental schools, but most clinicians don't use it. There will be some devices come to the market that'll make it much easier to use rectangular collimation. The fastest film speed possible, I know this sounds a little bit repetitious, but F-speed film has a 70% reduction in exposure time required to produce an image like this than does D-speed film. If you are not unaware of the film speed you're using, you can always look at the actual film image itself, and on the border you'll see some of these designations, the KS meaning ultra speed or a D-type speed film. The plus you may not see anymore unless you've got some older stock of Ectospeed or the E-speed film from Kodak or other manufacturers. And the newest one with the IN designation is the F-speed film, the one that has been produced to actually compete with some of the faster solid-state detectors. If you use digital image acquisition, if you use a solid-state receptor as the device for acquiring radiographs in your office, it is actually 90% less exposure time that's required than a D-speed film. And as you can see from the image on the right, you could actually do some image processing or alter the image to extract features that you may not have been able to see in a traditional X-ray film. In the next diagram, we will see the advantages of using an actual X-ray positioner.
The use of a film positioning instrument, such as the one pictured here, greatly increases your success of making an excellent radiograph. The patient bites on the bite block with the rod attached, and the ring shows the operator where to aim.
Of course, as we transition from a round cylinder to a rectangular PID, position indicating device or rod arrangement, the dose to the patient will be reduced even further because the actual size of the X-ray cone will more closely approximate the image receptor, no matter if it's film, a phosphor plate, or a solid-state detector. So there's, in actual fact, almost a 60% reduction in skin surface exposure with each image exposed. So there could be a significant reduction in the overall patient dose. If we look at earlier data that examined the dose in micrograys for the various procedures that we perform routinely in dental offices, you can see that moving in a full mouse series, for instance, from a round cone to a rectangular cone or cylinder actually ends up in over a third of a reduction of the actual absorbed bone marrow dose to the jaws. It only is about 2,500 microgray or thousandths of a gray. For bite wing procedures, the most common task we do in a dental office, that dose is 1/5 of the actual absorbed dose when a rectangular cone is used. And of course, this, just to equate it to a panoramic procedure, you can see that bite wings, 4 bite wings using a rectangular cone would have about the same dose as a single panoramic film. So panoramic is actually a very effective way of reducing dose and getting more information in your radiographic examination. There have been published some units of measurement. We saw them earlier. I just included this table here to kind of reiterate the different doses and dose equivalents of the units old and new. So my suggestion for reducing the patient's dose, including the use of faster receptors, also would be rectangular collimation and using a contemporary positioning instrument such as the one pictured here. When a receptor is placed in the bite block in the patient's mouth, the aiming ring makes it extremely easy and efficient to get the right image without causing retakes. The patient at final positioning should look something like this. If I had a more contemporary picture and had switched myself to rectangular collimation as we planned to, then you would see a rectangular cylinder actually aimed at the patient's central incisor region. We're now going to look at some of the laws and regulations that are local, state, and federal in this next segment. Federal guidelines are that only. They're guidelines that are suggestions and usually become standards within states, but they're introduced usually initially just to update and contemporize the way we practice our radiographic procedures. State legislation are usually in things like dental acts, and they are actually mandatory and expected that you follow those procedures within your office. The idea or the concept of a local standard of care, however, may not apply because on a national level, it's expected that with the communication capabilities we have these days, that every practicing dentist will do much the same thing across the country. In your particular state, there are 2 legislative documents. One is, you can see it numbered there, called X-rays in the healing arts, and that is primarily where some of this data comes from. There's also a general provisions document that has been amended, and I've included a website that you can download this information from. In addition, although it's not directly applicable to dentistry, it could be cited if there were a problem in your office and a reason for someone to investigate your radiographic procedures. There's also a chapter in your state called the Georgia Radiation Control Act, which some of you may want to take a look at. In the state of Georgia, as in most states, if you're operating kilovoltages between 50 and 70, and remember we said most of the machines are now fixed at 70 kV, there's the expectation that the total filtration, which is both the inherent and the added filtration in the machine, has to have a 1.5 millimeter lumen equivalent. In the state of Georgia, some of your rules and regulations describe the source to skin distance, or SSD. Basically the length of the rectangular or round cylinder. And what they've stated is that it should not be less than 7 inches. So in our offices with our, quote, 8-inch cones, we will be well within the guidelines. And that's if the machine is operated above 50 kVp. And as we said earlier, most machines these days are 70 kVp. If we move to the newer recommendations by the NCRP, they don't actually express it in source to skin distance. They talk about source to image receptor distance. And the image receptor, of course, is not at the skin surface. It's within the oral cavity on the end of that bite block. So what they've stated in their different sort of methods of stating is that it shall not be less than 20 centimeters and should not be less than 40 centimeters. So they're allowing some flexibility in the length of the cones that we attach to our X-ray tube heads. Also in your state, they talk about field limitation, and this is actually the size of that particular cylinder, the round cylinder that most of us use. The diameter of the useful beam that exits that X-ray tube it's stated in the X-Rays and Healing Arts Act, should not exceed 7 centimeters or about 2.75 inches. And they also state in this act that the positioning devices should be used to assure beam alignment. So the positioning device, the bite block, round sort of ring and rod arrangement that we showed earlier are actually being sort of specified in your state's Healing Arts Act to be used. If we think about the changes that are coming and have been suggested in December by the NCRP, the equipment they state shall be designed for use for intraoral receptors shall be capable of providing rectangular collimation to approximate the dimensions of the image receptor. Meaning, if you look at the small diagram, the actual cone, I hate to call a rectangular device a cone, but if you look at that cone and its rectangular shape, it's very slightly larger than the actual image receptor, so that it actually reduces the skin dose to the patient significantly. And the NCRP is making a shall statement here to say we should be moving to that particular arrangement and shall be using it in the near future. This is a little bit wordy slide, but just to show you the language that they used in this particular report. And I'll quote, "Rectangular collimation of the beam shall be used routinely for periapical radiography. Each dimension of the beam measured in the plane of the image receptor should not exceed the dimension of the image receptor by more than 2% of the source to image receptor distance." Quite a mouthful, but they said similar collimation shall be used when feasible for interproximal bite wing radiography. So they're really suggesting that we transition to rectangular collimation as quickly as possible. The next section we'll talk about is radiation monitoring, and this is what you do in your office to ensure that your patients and your personnel are safe. Of course, I have, in my earlier days, did I have any radiation concerns? Not at all. This is a joke, I'm sorry. I've got radiation dosimeters on my cornea, hanging by my salivary glands, over my thyroid, and of course down in the gonadal region. We do not do this, nor do we need to do this. In the recently released NCRP report, this is what they stated about radiation monitoring or putting badges on your patients and or personnel in your office. They stated that the provision of personal dosimeters for external exposure measurement shall be considered for workers who are likely to receive an annual effective dose of 1 millisievert. 1 millisievert doesn't sound like a lot, but remember, medical x-rays of all types to the patient population average about 0.39 millisieverts. So if your personnel in your office are using X-radiation devices routinely, it's really that you might consider it, but in actual fact it doesn't sound like it's totally proscribed or necessary. Also, they make statements about the pregnant occupationally exposed worker. And this statement says personal dosimeters shall be provided for known pregnant occupationally exposed personnel. So that if you have an office staff member, a hygienist, or a dental assistant who is routinely performing radiographic procedures, it's probably a good idea to arrange for dosimeters during that brief period of time that they'll be doing those procedures while pregnant. Another possibility is to not allow them to do those procedures, or you could also put a lead apron, as we do now, on that particular pregnant individual. But this is the recommendation as it stands currently. Radiation monitoring in regard to the pregnant patient has another sort of appendix in the NCR report that I thought would be useful for you to hear about, and I'm going to read this as well. There's also the concern, or always a concern, of exposure of a female who is pregnant but not aware of it. And those exposures happen occasionally in very early unrecognized pregnancy. The statement goes on to say that the absorbed dose to the embryo fetus is small, and it's similar to a gonadal absorbed dose and well below the threshold for problematic or deterministic effects. So they really don't know what effect there would be on the fetus or the embryo, but it was significantly low, probably unmeasurable. So that if exposure was required of that particular patient who was pregnant or unknown pregnancy, it should be conducted as to minimize the dose to the pelvic region. And we do that already with our leaded aprons, but as you heard, we're going to suggest we don't have to use that on an adult female patient or an adult patient. So if they don't know they're pregnant, it may happen. What you'd have to do is be prepared to talk to them and to describe the negligible risk that they underwent. In my practice, in many cases, if they say things like, well, I've had 2 or 3 miscarriages and I really don't want these radiographs just because I want to reduce whatever particular risk I might be at, then if the procedure can be postponed, we do that. They go on to state, however, that if dental care is to be delayed until after delivery, then the exposure should also be delayed. So they're giving you the opportunity to perform or not those procedures based on your estimate of the risk to the patient. This particular report I'm citing here, and I'll leave this up for just a few seconds so that you can see or write it down or record it so that you can maybe order the report. It's available through the NCRP group at 7910 Woodmont Avenue in Bethesda, Maryland. And just so you know that how the NCRP came about, this has actually been a group charged by Congress to establish protective policies and to look at the risks to patients in North America from all types of X-ray procedures. So they have a congressional mandate to do this and do publish exceptionally good reports that help us in our practices. The next section that I'd like to talk to you about is quality assurance. And although I know you've probably heard enough from the NCRP, a lot of the recommendations that they've made in this area are very good, and we need to consider some of these as well. Quality assurance involves many aspects of the dental practice: the monitoring of your X-ray equipment, the handling of your film receptors or solid state receptors, evaluating darkroom facilities, and we'll show you a few good and simple tests to do that, and really assessing the diagnostic quality of the image produced or the radiographic image that you have acquired. So we're going to look at most of these aspects in detail. The NCRP report did have a protection program that they suggested, and primarily this is for the people that are using conventional film, which is about 85 to 90% of the dentists out there currently, because only 10% are using digital procedures. So these will impact your office if you're still using conventional film. And it's going to become quite a significant aspect of your practice, because they're going to, in shell statements, suggest that you keep a written quality assurance protocol or manual, that you actually establish one in your office, that you have different aspects or different components of your X-ray systems inspected by experts, and that usually is mandated in states anyway on an annual or sometimes biennial basis. They're going to ask you to evaluate and document the chemistry daily, evaluate each type of film once a month that you use in your office for artifacts or fog in the box or out of the box, inspect screens and film combinations, especially the screens for panoramic and cephalometric use. If they've had any type of accident, a scratch or been dropped or whatever, there's going to be monthly inspection of your screens. And then suggest that you repair, of course, any defect that you'd uncover. If you do not use conventional film, you would not be using screen film combinations. You would be using just a solid state detector and not have to worry about some of these particular aspects. They want you to look at your darkroom closely, and they want you to do that monthly inside the darkroom for light leaks. Make sure the filters have no damage to them and that the lamps are not actually causing light leakage within the darkroom facility. They're going to ask you to inspect the leaded aprons monthly. Again, we've seen the changes in the apron use, but you still will have them in your offices for pregnant patients and children, so you'll have to inspect those on a monthly basis. And they're asking all dentists in the country to provide training such as you're getting from this particular continuing dental education program in all aspects of radiation protection, so that your personnel in your office understand what's required to have a quality radiographic practice in your office. Here's the first statement I thought I'd share with you, that dental X-ray machines shall comply with all the applicable laws, standards, and regulations governing their manufacture, installation, and use, and with all recommendations in this report. So what they're saying is, if you have state regulations or guidelines, you need to be cognizant or aware of those and make sure that you're practicing in that manner. Older equipment shall be brought into compliance with these recommendations or be replaced, so that if you have an X-ray tube head or generator that has a round cylinder and the recommendation is a shall statement to go rectangular, it may be that you have to change out your tube head, buy a new machine, or find some type of equipment that adapts to that tube head to comply with the rectangular collimation. In another portion of the report, it says that dental X-ray machines shall provide a range of exposures suitable for the fastest image receptors, appropriate for those clinical procedures for which the machine was designed and available at the time of manufacture. So what they're saying here is that you have to have that accurate timer we talked about earlier. Well, let's talk about monitoring your X-ray equipment. There are several areas you have to consider, including tube head motion. We all know that with use, our tube heads tend to drift a little bit, especially if they've been, quote, abused in the dental office, or, you know, where I teach in a dental institution, sometimes they will not stay stable, and that has to be rectified. Monitoring the MA, KV, and timer needs to be left to the experts, you know, the radiation safety officer that comes in periodically, or if you're having exposure problems, you call someone in that is certified in your state to actually examine those features of your X-ray machine. The energy of the beam, we'll talk about how you can make sure that you're sort of compliant or have the most contemporary sort of machine. Collimation, and then where you see that little asterisk at the end, we'll actually show you a very simple film pattern test that you can create in your office to make sure that your collimation is precise. And also the focal spot size, which again you would probably have to leave to a radiation safety expert. The tube head motion. Here is the statement: the tube head shall achieve a stable position free of drift and oscillation within 1 second after it's released at the desired operating position. If you move the tube head into a position to take, let's say, an anterior incisor view, within 1 second there should be no motion to that tube head. The drift during that 1 second shall be no greater than 0.5 centimeters, meaning if it does drift, it can't go any more than half a centimeter, which is a very small distance, so you would have to reposition it, but they're suggesting that, you know, if that happens, you may have to have that tube head repaired. And then the operator shall not hold the tube head during exposure. That's only common sense. No one should be in the room at this point in time when the exposures are being made, except the patient or someone with leaded apron and protected gloves if they have to hold a patient, let's say someone that's developmentally disabled. So let's do a little animation or a little diagram of what we could do to actually check the collimation of our tube head. If you're using a round cylinder, such as pictured here, and you put in 4 films at different locations, 4 different sort of 90-degree positions, basically once you expose those films centered under the cone, you should have a pattern that looks like this on the exposed film area, so that you would have an area that had an exposure on it where the collimated tube head has beamed down onto the film, and the rest of the film where the white areas are would be blank. So if it was a symmetrical pattern, then you would have a precise collimation of your beam. If not, then you're required to try and correct that, which would require a visit by a dental representative or your radiation safety officer, an examination of the tube head. It could be down for a short period of time. Now, with the rectangular collimation, the statement was that equipment designed for use with intraoral receptors shall be capable of providing rectangular collimation to the approximate dimensions of the image receptor. We saw this earlier. They stated it as a 2% limitation, but this is a more simple statement of what they would like us to try and transition to. If we move to film receptor or film and/or receptor handling and storage, of course there's different considerations for conventional X-ray film than there are for the solid state or phosphor plate detectors. If you're looking at conventional X-ray film, you'll want to store that film in a dry, cool place. You want to store it away from heat and radiation for that matter. You don't want to be storing your film in an operatory that you're exposing patients in all the time. And you should, of course, never use expired film. It's tempting to buy it in bulk, store it, but if you've got a year-end sale, you may want to dump that film and get fresh film. For phosphor plates, for those of you who have switched to some reusable or storage phosphor detectors or phosphor plates, these must be stored in subdued light, because if they're actually sitting out on a countertop, the ambient light from the room actually will get into the phosphor coating and could affect the subsequent image. It would actually degrade the image somewhat, making it usually quite a bit lighter. You also want to avoid rough handling. There's a lot of people that are attracted to the phosphor plates because they're less expensive than solid-state detectors. But if you have them sitting on a countertop and people are picking them up and using them, they can be scratched. The surface will then have a built-in sort of air on it, and that will show up in every image after that. So they do take some care in feeding, and you want to avoid rough handling. If the image is a pure light, first of all, look at your storage capability and the way you store your phosphor plates, but if they routinely look light, they may require replacing. There has been recent study published by people at UMKC, University of Missouri, Kansas City, that showed that after 50 uses, the plates start to degrade. And yet we have manufacturers that tell us that they can be used for 500 or 1,000 uses. So this may not be the case. You do not know which plates you're picking up each time, because there's no way of knowing if you've already used it for 50 procedures, so that as they appear different from other ones taken in the series, you may have to replace them. If you've transitioned to solid-state detector systems, they take a little less care in feeding, but of course common sense says that you would not bend the cable, the fiber optic cable that actually carries the signal, and you'd want to avoid rough handling, care not to drop them, because if they're dropped, that could affect their handling and performance and the eventual image quality. So they have to be handled with reasonable care. If we go to conventional film again and look at evaluating darkroom facilities, there's some suggestions that you should, or procedures that you should perform probably on a daily basis, some on a monthly and some on an annual basis. Daily, you should check the temperature of your processing solutions, make sure that the solutions are within the temperature range that's ideal for processing a conventional film-based image. You would probably want to have some sort of automatic replenishment system for the processing solution, and the fixer for that matter as well. If you do not have automatic replenishment, there are ways of using a check or reference film that will show you that says, hey, it's time to replenish or time to replace those solutions. You also can create a very simple, inexpensive step wedge film in your office for looking at the overall processing solutions, and we'll show you how to create or make both of these little tests, the reference film and the step wedge film, in just a second. And also, again, it's good to enter these findings in a QA logbook for your radiographic procedures, and it is one of the recommendations that the NCRP has made as a shall statement. Of course, I don't know how many people do this in their practices. We do this routinely in dental schools. You should record all retakes so that you can actually go back and possibly calculate the actual dose the patient received if necessary. So you should record any retakes taken in your office, and I'm sure that in many offices that is not done currently. The check film. Check film is a very simple thing that you can use. All you do is take a unexposed radiographic film. You'd want to expose an image of a penny, or maybe you've taken a film on the first patient after changing your fresh solutions. Keep an extra copy of that on a view box. And when you view it on the view box, you'll see an ideal sort of set of characteristics, density and contrast. This is really your check film. This is the first film taken in fresh solutions. Maybe you could use a double film pack and then mount it on a view box. Then daily, using the same settings, what you'd want to do is re-expose an object. It would be preferable, but if it were the first patient the next day, you would take one of those films and compare it to the first film or the check film first thing in the morning. If you compared that new film and if there was a noticeable difference, if the image quality was different, then of course you would have to change the solutions. Another office quality assurance check or procedure that you can do is called a film wedge, and this is very easily constructed in your office. The yellow represents a tongue depressor, which we all have in our offices, onto which we would tape the inner lead foil from a number 2 size film. You can see it, the gray area with the herringbone pattern on the left. And what we'd also do is take 3 or 4 thicknesses and just gently overlap them so that area 1 would have a single film thickness, area 2, 2 film thicknesses, area 3, and 4 accordingly, so that they will be forming a step wedge with different object density when you expose them. So you tape all 4 of these to your tongue depressor, then basically expose an X-ray film over top of this region and process it in fresh solutions. And what you'll get is a pattern that looks something like this, with the most exposure being where the single lead foil was, so it'd be the darkest area, and stepping back to the lighter area where 4 thicknesses had been used. And you could put this up on your view box, the resultant film, and compare it to one that you would take each day in your office. So you'd place another X-ray film on, re-expose it over that step wedge, and make sure that the densities in those various grayscale areas were comparable. If they became too light, as your solutions become spent or not replenished or need changing, then of course you would have to change the solutions within your automatic processor. You also need to evaluate your darkroom facilities on a weekly basis. Certainly in busy practices, fixer and developer solutions in fresh water should be changed each week. You need to clean the processor during that period of time, the roller assemblies and also the inside portion of the automatic processor. You should actually record a log first of all and then review it to make sure that if you found a problem that the corrective action was taken, and have whoever performed that procedure enter their initials showing that they did the corrective measure. There are also steps you can take to evaluate your darkroom facility if you're using conventional film. On a monthly basis, you might want to check your darkroom for leaks, and we'll show you a penny test, a simple test to do that with. You'll, of course, if you're recording retakes, you'll want to review those with your staff. Oftentimes that will identify someone who maybe has started to take poorer radiographs and they've forgotten some type of instruction that they received, and you can actually update them and say, hey, you're making this same mistake periodically, here's how you correct it, and so it helps to identify possible personnel problems as well. And you'd want to take the corrective actions for this, including staff retraining and the darkroom leak correction. Annually or every 2 years, biennially, you would, in most states, have to have a radiation inspection by someone certified in the state to inspect your facility and your equipment, not only the darkroom but also the equipment in your X-ray tube. I'd like to demonstrate a simple penny test that you can use for checking darkroom light leaks. A very simple, inexpensive test. If you take a copper penny and place it on a number 2 size radiographic film and expose it for a few seconds to X-rays in your operatory, and then process the film, when you take it out of the darkroom, it should look like this. If you wanted to check for light leaks in your darkroom, you could take that same penny, place it on a number 2 size film, and leave it in your darkroom for a day or 2 days. Open it in the darkroom itself, process the film, and if you saw the image of a penny, of course, then you would have a darkroom light leak at that point in time. Just as a simple aside to show you the advantages of digital imaging, this is a penny that was exposed on film and run through processing chemistry in the darkroom, and you can see a white circle on a dark background. If you're using digital image receptors, then when you expose it to about 1/100th less exposure, about 4/100ths of a second rather than 4/10ths of a second, the image would come up instantly and look like this. Of course, you could process the image on a computer monitor to actually enhance the contrast or the density, and indeed you could even colorize it. This is not capable, is not a capability you would have doing conventional film, and certainly wouldn't be a darkroom test, but just an interesting sidelight. Let's now move on to what we would consider to be a diagnostically acceptable radiograph. If we were looking at a film image of our patient's problems or anatomy, of course the film would have to have acceptable contrast, acceptable density. It would have to be correctly positioned with the region of interest centered in the image, and it would also have to be free of image geometry problems, that is, overcorrection or undercorrection of the beam, which we normally call foreshortening and or elongation. This is an example of two films, and one shows a low contrast image on the left where it's more difficult to pick out trabecular bone, maybe the gutta perca or the root canal filling material within the tooth. The image on the right with correct or acceptable contrast really is a preferable image for making diagnostic decisions on. You can also have over a contrasted image or an image with too high a contrast, and in this case we lose some of the definition and anatomy in and around the molar crown on number 31, and perhaps we have, quote, burned out some of the areas at the alveolar crest in between the teeth. So we can have too little contrast, as we saw in the first image, and too much contrast, and really we're striving for the image seen on the right. A lot of this image contrast has to do with the penetrating power of the X-ray beam. The X-rays in the beam normally are around 70 kV when we select that exposure setting. Those, of course, would be less penetrating than 90. And to diagram that, if this were the mean energy of the beam around 30 or 35 keV of a 70 kV machine, this would be moved up in a 90 kV environment to around 40 or 45 kV in the average energy of an X-ray in the beam. But the 70, because it does not penetrate the patient but stops or resides within the patient and the image receptor, would actually produce a higher contrast. So the lower the kV, the higher the contrast. The acceptable contrast in a radiographic image is also, or the contrast required for a different task might depend on what you're looking at. If you were looking at interproximal carious lesions in between teeth, you would like to have a high contrast image. However, if you're looking at subtle or fine bone changes at the alveolar crest, you may not want as high a contrast as that used for interproximal caries. The next area is acceptable density, and that is the film's overall degree of blackness or darkness. And the factors affecting that, some of which we can control, some of which we can't control. The subject thickness, for instance, we cannot control our patients' sizes as they come in. Patients come in different sizes, so we'd have to only maybe alter or change our time of exposure in order to penetrate the tissues of a larger subject rather than a smaller subject. Also, the exposure time is fixed on some machines in terms of icons or lookup tables if it's a molar view. But if it's a molar view on a thin patient and requires half a second, on a larger patient it may require 3/4 of a second. So you have to pay attention to both the subject thickness and the exposure time and be prepared to alter it accordingly. Of course, if you're using conventional film-based radiography, the processing chemistry can alter or modify the overall density of the film image. If your processing solutions are weak, if you're not replenishing routinely and automatically, then you might have a lighter film, which is a lower density and would be less diagnostic. Also, the temperature of that particular solution. There are optimum time and temperature for settings rather for processing conventional film in X-ray processors, and if the temperature is too high, it might lead to a dark film. If it's too low, it would lead to a light film. So the temperature is important. The time of your processing is important. Most automatic processors have fixed times. Sometimes we tend to want to get the image faster and we speed up the time of processing, and this can also alter the actual density of the image, sometimes to its detriment. Another factor affecting the film's density can be the distance from the source. This reflects back on the inverse square law. The further the object from the source, the lower the intensity of the X-ray beam. So you'd have to remember back to your inverse square law. There is an ideal distance, usually fixed by the length of the cone, but you remember that you can slide that ring closer or further from the patient. You'd want that ring close to the tissues in order to keep that distance of the film receptor closer to the ideal. Now, if you look here, you can see that there's an acceptable density on the top film, but the lower film has an overall higher degree of blackness or higher degree of object density. So this would be a less diagnostic film. And these are difficult to recover in conventional film-based systems. In digital systems or solid-state detector systems, of course, you could perform image processing to extract more of the features about an initially unacceptable film without performing a retake. Now, the rules for maintaining contrast while maintaining the same density are quite well known, but it warrants review. To increase the contrast when the original kV is set, if you want to decrease it by 15, you'll have to use 2 times the original exposure. So if you are decreasing your kV in your machine by 15, it takes twice the exposure. However, as we discussed, in dental X-ray procedures, we rarely have the opportunity to adjust the kV. If you want to decrease the contrast, of course, you can increase the original kV by 15, and you'd have to use half the original exposure. These are much more appropriate for medical procedures, but you could probably make a correlation to the dental. Correct placement, there are 4 concepts that I actually consider when trying to get a full mouth series of diagnostically acceptable radiographs, and I'll explain these as we go along. Let's say you were doing the central or lateral incisors. You would want to center that particular tooth as the region of interest in the middle of the film. That would do for all the anterior films, centering the tooth of interest. We all have heard the expression distal half of the canine. There are reasons for getting the distal half of the canine, which we'll re-describe for you in order to open up interproximal contacts areas for detecting interproximal cavities. You'd also want to center the second molar in a molar view, and I'll explain why in a minute. And then a kind of an unusual concept of moving in the bite wing examination only about a tooth and a half. And I know that's confusing right now, but I'll explain it in a second. So if we were taking this upper left canine view or cuspid view, the canine is the tooth of interest or the region of interest, we would want to center our receptor on the canine, and you'll see in the diagram on the bottom left a bite block and the canine centered on the bite block. You'll also see that bite block, the image receptor is quite a distance from the tooth, and that's acceptable. You want to work out in the middle of the palate in order to increase the height of the area that you're placing the receptor in so that you can acquire it easily and not get angulation errors. And you can see that the image on the right depicts a reasonable image of the canine. The distal half of the canine is an important concept because in our anterior views we often have overlap contacts because of the curvature of the arch in the anterior palate. So the distal of the canine is important to show on a diagnostic image of the premolar region so that if there were interproximal caries on the distal portion of that canine, you would actually see it in a, quote, open contact view. I often ask students which cuspid is more anterior, the upper or the lower, the maxillary or the mandible. And in this diagram, or this picture rather, you can see that in actual fact the lower cuspid is more anterior than the upper. So if a patient is having bite wing examination and they've closed on the bite wing tab or on the instrument, many people, because the canine on the top is more prominent, tend to look for the distal half of the upper canine. However, on a premolar bite wing view, if you wanted to get both distal portions of the canines, you would have to actually eyeball or look at the lower cuspid, since it's more anterior. So just to review, it is the mandibular that's more anterior. Now, a word of caution here. When you're doing or trying to actually capture the distal half of the upper canine, sometimes there'll be the tendency to bring the image receptor too far forward. And if you do this, especially if you're using an instrument like a RIN instrument or a rod and ring, then basically you're going to start to overlap contacts in the posterior region. And I'll show you an example of that right here. You can see in this film that the operator moved the film too far forward. They're way past the actual upper canine, and they're actually picking up the distal of the lateral incisor near the letters KS. So what that's done is that's forced the contacts to be closed in the posterior region. If it had been placed properly, we would have opened up those contacts as a secondary view or look at interproximal caries. Now, I'm a little bit at odds with many of the textbooks that are out there in terms of radiographic technique, where they tell you in the molar view to capture the distal half of the second premolar. My feeling is that especially on the lower, the third molars often have curved roots or are mesioangularly inclined, so it's much safer, even if the third molar isn't present and we're assuming it's unerupted or impacted, it's much safer to actually center the second molar, and it's an easy concept to keep in your mind. If you center the second molar, you'll rarely ever miss a third molar that's in an appropriate position. Of course, there'll be some horizontal impactions and others that you won't be able to capture and have to move to a panoramic or some other type of film. This is the concept that sounds confusing at first, but will help you tremendously when you do your bite wing radiography on your patients. You know that in most full mouth series we take both a premolar and a molar bite wing view. And the tendency, because the operator, in many cases the dental assistant or hygienist, does not want to miss the last tooth, they tend to move that molar view film position too far back. And we'll show you what I mean by that. It only requires, because the task is to look at interproximal contacts, that the film be moved from the premolar view about half the cuspid width plus the width of the first bicuspid. So that's where we come up with the expression of tooth and a half. And this is what I mean. If we had a premolar or a molar view that looked like this and the third molars were actually present, we would only have to go this far back in order to show the interproximal contacts between the second and third molars. To diagram it a little bit differently, you can see that I haven't moved very far from the film on the right, which was the premolar view, to the film on the left. Even though they're different patients, you can see that we've only moved the distance of the cuspid, half the cuspid and one premolar, and yet we would have captured all of that image information in the interproximal contacts between the second and third molars. Let's see it another way. There's the distance that we moved, by the way, but let's see it another way. We'll take a barely acceptable interproximal premolar bite wing view where we see just barely the distal of the upper and lower canines. But if the third molars were present in the maxilla and mandible, we'd really only have to move that distance that you see outlined in yellow in order to capture those two molars. Again, we don't have to see the distal of those third molars because we could see those clinically in the mouth. We actually are just trying in a bite wing examination to open up the contacts between the second and third molars. So you really only have to move a tooth and a half. The correct image geometry is necessary for a diagnostically acceptable radiograph, and basically what it boils down to is that we should be using a paralleling technique and working out on the end of the bite block. we want to avoid bisecting angle as a routine procedure and move towards paralleling because there's inherent image geometry problems with bisecting angle. This is what I mean. Here's a maxillary and incisor view with elongation because of improper vertical angulation. We cannot see the apices of the tooth, so that we actually have geometric distortion built right into bisecting the angle technique. Magnification and image and sharpness also in that technique. If we were using a bite block with a proper beam alignment and the object centered in the film and our X-rays came in perpendicular to the film receptor, you would have the apex of the tooth cast in a region somewhere on the upper portion of that film. But if we come in at too steep an angle, which is often the case in bisecting the angle because it's kind of using imaginary lines that you're trying to eyeball on the patient, you could see that the actual root end of the tooth would be cast much lower down. So we'd get the error of angulation, vertical angulation, called foreshortening. As we said, the bisecting angle technique has inherent errors built into it because of angulation problems. Let's examine that now. If this represents a paralleling instrument with this tooth centered on the film, if the X-rays come in right angled to the film plane, then we would have a nice stable image and a very correct anatomic image of the central incisor. However, if the X-ray tube were angled severely downward in too steep an angulation, this would cast the root apex of the tooth down onto the image of the film, or down onto the film in a what we call a foreshortened appearance. So you would get an actual image of a tooth that's shorter than it really is, and this of course can cause some problems diagnostically. By the same token, if we have the correct image and we come in at too shallow a vertical angulation, we create what you remember is an error of angulation, vertical angulation, called elongation. That is, we cast the root apex of the tooth up higher on the film, and we get an elongated view of that image, which again would be diagnostically unacceptable, especially if we're using this as a periapical view of that region. If we are working with a paralleling instrument and want a diagnostically acceptable image, we really do need to work in an area that I call out on the end of the bite block. So we really want to move that object or the tooth a little further out on the bite block, represented by the gray area, and place our image receptor at a little bit different distance so that we get a very nice view of the tooth. This would allow you to work with the patient's anatomy within the restrictions given by things like shallow palates. So working on the end of the bite block will improve your diagnostic quality of these images. So in this section we've reviewed quality assurance, some procedures that you can take to ensure your darkroom quality, to ensure your machine quality, and to help you produce the very best diagnostic radiographs possible. Thank you.
Hi, and welcome to the next section on practical concepts for radiographic technique. In this section, we will outline several simple concepts to help you achieve the very best radiographic images possible, no matter what image receptor you're using. These practical tips will work with film, phosphor plates, or solid-state detectors, wired or wireless. The proper positioning of the image receptor allows you to maximize the image information you need to interpret carious lesions, periodontal bone loss, and early periapical changes related to pulpal or other odontogenic problems. You must remember that we are trying to represent three-dimensional objects on a two-dimensional film or other image receptor. This is not an easy task. The image on the left is not actually three-dimensional, but has shadowing to characterize it as 3D. So minor tooth positions will end up with overlap in contact areas or different looking images because we see them as two-dimensional and not three-dimensional. There are a myriad of factors involved with creating an excellent diagnostic quality film. Things like density and contrast we have no control over in terms of kV or MA. All we can control is the time. Other fixed aspects are the focal spot and the alignment and shape distortion built into techniques such as the bisecting the angle technique. The bisecting angle technique probably is not useful in this day and age given the good instrumentation that we have. Bisecting angle has inherent distortion built into it and also is fraught with operator errors. There is inherent distortion in never having the long axis of the tooth parallel with the receptor, and the high possibility of an inaccurate vertical angulation since the operator is really guessing at the correct angle. The film on the left is correct. The film in the middle has too steep an angulation causing what we term foreshortening, and the film on the right has too shallow an angulation causing elongation. When you add to these potential errors other built-in geometric problems such as distortion, magnification, and unsharpness, it's a wonder anyone can obtain a diagnostically acceptable set of images using the technique. It takes a long time to master bisecting technique, although it does have its role as an ancillary method for things like endodontic films in some cases. Improper vertical angulation, although minimized in the paralleling technique, can also be a problem. If the central ray is perpendicular to the long axis of the tooth, the shadow is cast very accurately. If the central ray is too steep, as depicted here, the shadow of the tooth will be foreshortened. The opposite of foreshortening is elongation, seen here when the vertical angulation is too shallow. The image of the apex is cast too high up on the film or receptor, and the tooth appears much longer. These vertical errors, however, are greatly minimized by paralleling, since there are many visual cues to see outside of the patient's mouth to perform the technique correctly. As you know, teeth are not straight up and down in the mouth, especially in the anterior region. So if we use the bisecting the angle technique, we actually will slightly foreshorten the tooth image if we place the receptor correctly and bisect the angle formed by the film in the tooth to bring our central ray in perpendicular to the film or receptor. Therefore, paralleling will work best in all cases. When taking films, we know that some teeth are more difficult than others. The canine, because of its long, pointed appearance, can be a problem. So what we do is we add a cotton roll to the underside of the bite block so that when the lower or the opposing tooth bites into the cotton roll, it will stabilize the occlusion. You can place this cotton roll at any time during the placement of the bite block and image receptor. The paralleling technique is the best technique for all intraoral films. Paralleling, however, does require the use of an aiming instrument called a PID, or position indicating device. Here we see a patient in the final position for an anterior film, and the cone parallels the bar on the image receptor PID. If we look at the instrument and place the receptor in the slot, we should be able to look through the ring and see the perfect placement. Here is the resulting image of a molar view, a third molar region, where we've centered the second molar and captured a very diagnostic film. Just as in selling real estate, there are 3 or 4 important rules or concepts to remember. The first is location, and like selling real estate, the 3 most important concepts there are location, location, location. We can see here that with appropriate placement, we do capture the distal of the canine. I also want you to note that the minor overlap between the second bicuspid and first molar is probably due to tooth position, since the rest of the contacts are open. This is not the dental assistant's fault. So we have 4 concepts that I believe will help you achieve the best diagnostic set of radiographs or images. 1, we center the tooth or region of interest. 2, we always capture the distal half of the canine or cuspid in the premolar periapical views and the premolar bite wing view. 3rd, we center the second molar, and in this manner always capture the third molar region. And 4th, which will take a little bit of explanation later, in a bite wing set of films, we only move from the premolar bite wing view to the molar bite wing view a tooth and a half. It goes without saying that the object of any view of the teeth and bones should show the region of interest in the middle of the film. Here we see an endodontically treated first molar centered approximately in the film. This could not be used to identify the third molar region, which we see as unerupted or impacted, but is an excellent view of the region of interest. Any tooth or region of interest should be seen in the middle of the bite block on the ring. In the image on the right, we can see the view of the canine centered on the bite block. We also see the cotton roll underneath the bite block to stabilize. Please look at the image on the left too, because you can see that we work far out on the end of the bite block in the middle of the palate to give ourselves the best opportunity for a perfectly paralleled image. It is important too, in the second concept, to remember that we have to capture the distal half of the canine or cuspid in all three views, the maxillary and mandibular premolar views and the premolar bite wing view. In doing this, we can see identified by the pink line, we'd be able to see the early interproximal carious lesions on those teeth. The reason we want to capture the distal half of the canine, especially in the maxilla, is because the palatal cusp of the first premolar almost always overlaps the distal half of the cuspid. This results in the image you see at the right, where the X-rays pass through these teeth and the palatal cusp is superimposed on the canine. We could not use this for detecting interproximal decay. If the dentist wanted to see a carious lesion on the distal half of the canine, then we have to show those areas. The image on the left shows the overlap on the cuspid view. The premolar bite wing view shows both the maxillary and mandibular canine contacts open. I have to pose a question to you. Which cuspid or canine is more anterior, the upper or the lower? While you think about that, let's look at a picture. Well, some people think that the upper cuspid is more anterior because it's more prominent. But in a class 1 occlusion, the lower cuspid is more anterior because of the size and the smaller sort of curvature in the anterior region of the mandible. So when you're placing a bite wing film, a premolar bite wing film, it's important to visualize the anterior edge of the film capturing the distal half of the lower cuspid, not the upper. If we look at this picture, we can see that the maxillary canine or cuspid is more posterior to the lower. So when you position your bite wing image, you always want to capture the lower canine. A word of caution: if you place the image receptor too far forward, especially using a PID or aiming instrument, you will then of course close contacts in the posterior part of these premolar views. This is important because these can be secondary views to look at interproximal contacts to determine if there are carious lesions. Here we see the operator moved all the way up to the lateral incisor, closing all contacts in the premolar and molar region. This would be a useless film for interproximal information. The third concept is to center the second molar. Some books teach you to capture the distal half of the second bicuspid in the molar view, the molar periapical view. You can see, however, that if this third molar had even a slight curvature to its root or was mesioangularly impacted, then we would not see all the region of the third molar. I would like you to think about always centering the second molar because of the curvature of third molar roots and their inclination to be impacted or tipped mesioangularly. The image of the molar depicted here shows all of the molar apices, including the severely curved or dilacerated distal root of the third molar or wisdom tooth. If we had captured any of the second bicuspid, we would have missed this important apical region. If you compare these two images, the image on the right is not a good view of the third molar region. It was, however, used to capture the information about the endodontically treated first molar. The image on the left you just saw captures all of the third molar region, so it would be preferable. The fourth concept requires a little explanation. We call it a tooth and a half. And unlike the periapical views where you must capture all of the root apices and move far enough posterior to capture the third molar region, in the molar bite wing view you only need to move from the premolar area to the molar area, the distal half of the canine and the bicuspid behind it, which amounts to a tooth and a half. If you look at these two images, although they're different patients, the arrows indicate the distance that we moved, half the distance of the lower canine plus the bicuspid. If the third molars were present in the left-hand image, we would see the interproximal contact information between the second and third molars. If we were using these, of course, for estimation of bone level, we might have to take some selected periapicals, especially in the maxilla, where you can see the bone is missing from the bite wing view. However, if we're using these for interproximal contact and caries detection, we would not need to see the distal surface of the third molar since we could see those clinically. As an example, or another example, here we've moved back a tooth and a half from just barely capturing the distal of the canine and the maxilla and mandible, but you can see that if the third molars were present, we would have the interproximal contact information to make our caries diagnoses. We're going to demonstrate the bite wing views, and if you remember, we only moved distally, or we only moved towards the back, a tooth and a half the distal of the canine and the premolar view. In Dr. Shelley's office, he's got two ways of doing this. We can actually put a little sponge tab on here that Shannon can bite on, or we can use a digital receptor, which we'll probably demonstrate in a second. Let's get a sponge tab. These are kind of fun. They fit on very easily. The only problem with using these devices is when the patient bites on here and they close very, very closely, it's difficult to see the actual position of the teeth. You know, did my anterior part of my film meet my criteria, capturing the canines both top and bottom? And if you recall from the program, the canine on the lower, in the mandible, is actually more anterior. So that's the one I'm going to eyeball. Can you open big for me, Shannon? Okay, I want you to close gently, just start to close. Good. Okay, open a bit, close a bit. Good. Looking here, I can see the distal of the canine on the lower is actually going to be captured on this film. Now, horizontal angulation is critical here, and I might bring that tube head over. Thank you, Tanya. And what we might do, because we have no aiming instrument this time, what we have to do is bring our central ray in perpendicular to that particular film plane. And can you do this for me, Sharon? Just do that. She helped me out a lot because I was a little too far posterior. We want either 0 to about -10 or +10 angulation, and I can see that I will capture the whole film image. The anterior part of my cone is going to capture that front part of the image receptor or the film, and I'll get the distal half of both canines. Okay, next we're going to demonstrate the bite wing views, and the first one is the anterior or the premolar bite wing view. The rod that we're using is a very simple rod. We're having a bite block, and this one it's a little bit loose, so I'm going to have to be careful with it, but this bite block will hold our film receptor. The rod goes on. This is the same rod as the anterior ring, but we're just using it with a different bite block. The easiest way to actually fit these films into this, and again, the sensitive side has to face the X-ray tube, is to put one side in the bottom, flex it outward, and let it catch itself in the top, and that way it'll stay nice and stable. Okay, Shannon, what we're going to do is we're going to carefully put this in, and I'm going to eyeball this towards your lower canine. Just start to close for me. Good. Close, bite. Now what I had to do in Shannon's case, because she has a little bit shallow floor and those mandibular tori, I actually had to rotate the instrument slightly towards the midline, and in doing that I actually then forced myself to come in at the proper angulation to open that anterior contact. I will slide this ring close again, and just like we did with the other sponge tab, we would bring our tube head in, parallel this rod, and we would capture what we hope would be the distal of both canines. Can you do this for me again, just like that? Looking through the ring, I can just barely see the film receptor inside, and I can see that I will capture the distal of the canine. Okay, can you open for me? Now, the concept that we talked about in the program was a tooth and a half. We are only going to move back from half of the distal canine and the premolar in order to capture the contact information between the second molar and the third. You open big for me again? This is very easy to visualize. Okay, close for me. Good. And you can see that I'm slightly further back, but not a lot further back. Grimace for me again. Good. I may have to go just a touch further. Can you open for me? Close again. Good. She allowed me to go ahead and reposition, and you need to take a look and make sure of your position before you make that exposure. In comes the tube head. Make the exposure for the posterior bite wing view. So although these are different images of different patients, if we put a set together, we should get a very nice series. This area, or these images, represent 1/2 of a full mouth series, using number 1 films in the anterior to capture the central incisors, the lateral incisor, and the canine. In the mandibular region, just the central incisors and canine view. In the posterior region, number 2 films in horizontal direction are used to capture the premolar regions, premolar periapical regions, and distal half of the canine, and the periapical molar areas to show all of the third molars. You can see also that in the bite wing views, we've moved simply just a tooth and a half to capture all of the contact information, and capture more contact information than if we were to move more distally in the molar view. So let's go one by one through these techniques for each of the views. In the maxilla, we would have to center the central incisors, center the lateral incisor, center the canine or cuspid, include the distal half of the cuspid on the premolar views, including the bite wing premolar view, and center the second molar. Here is a schematic of the maxillary central incisor. You can see that our film receptor would capture the centrals centered and most of the lateral incisors. And note that we're working way out on the end of the bite block, getting the image receptor in the center of the palate. This is a short video showing the actual placing together of the instrument and the maxillary anterior incisor view. First of all, we have to assemble the instruments, of course, and there are several components. The anteriors are the easiest to begin with, and the anterior bar is the one with the most turns in it, the most complicated. You want to work out on the end of the bite block, so we're going to actually insert in some holes out on the end of the bite block, and we're going to put the ring assembly on fairly close to or proximate to the actual bite block itself. For the anteriors, in most offices, we use a size 1 film, and there is a dot, an embossed dot that you can see on the back of the film in black. The dot goes in the slot, okay? That's a nice term to remember. If you put the dot in the slot, then it won't be over the apical region, which could interfere with some interpretation. So Shannon, if you could tip back into there again, what we're going to do is we're going to place this particular film for the central incisors. What we want to do is have the patient open wide. We're going to work out very far on the end of the bite block. Can you just open? We'll tip it here. And I tip it up. Is that contacting your palate, Shannon? Mm-hmm. Okay, and I want you to close very gently against that. Okay, as she closes against that, we can slide the ring down close to her face. For demonstration purposes, we're not going to put the actual tube head in here at this point in time, but we would bring our tube head in. It would parallel this rod. If you could turn your head this way just a little bit. If I look down through the ring, I can see that her central incisors are perfectly centered on the bite block, which means if I trust the rod, I put my X-ray tube head in there, we'll get a perfect image. If we do things correctly, this should be the resultant image. The central incisors well centered, and most of the root apices of the lateral incisor showing. We're not too worried about missing the lateral periapical region, since we will get that in the next view. When we're performing the maxillary lateral incisor view, we want to center this tooth, of course. The diagram on the right shows the lateral incisor centered on the bite block, and again we're working out in the middle of the palate. Here is a short video of the capture of the maxillary lateral incisor. Okay, the next view that we can do in this series is the lateral incisor view with the number 1 film. Shannon, could you tip your head back again? And if she opens wide, I can see a nice lateral incisor. I'll tip the instrument onto it. I'm working on the end of the bite block, and just start to close gently. As she closes, however, I notice that this is going to rock or tip a little bit. So Shannon, can you open for me? I'm just going to take that out. And this is where you've seen in some of the previous parts of the program that we put the cotton roll on the opposite side. Some people will actually use a little rubber band and actually put it on the bite block. I don't do that necessarily. I just put it in where it's needed at the time. So Shannon, open again for me. And then tip this up. You doing okay?
Mm-hmm.
Okay, just close gently for me. And as she closes, you can see how stable that is, and she's not pushing the film into the roof of her mouth. Again, I would bring the tube head over, position it here so that the tube head and this rod are parallel, and we'd capture a nice view. Okay, can you open for me? The resultant image using this technique shows that the lateral incisor is quite well centered. We even get the apices of the central and the cuspid on this view, and you can see the overlap between the lateral incisor and canine, and especially the canine and first premolar, with the palatal cusp being superimposed over the distal of the canine. For the maxillary canine view, obviously we center this tooth, again working across the arch and out in the middle of the palate. Here is a video representing the placement for the maxillary canine view. Can you just tip back for me again? The cuspid, as you know, has kind of a pointed sort of clinical appearance to it, so this is one that almost always rocks unless you use the infamous cotton roll. So if you open again for me, sorry, we'll find the cuspid on the center, and you can see I'm working well back in the mouth, and I want you to close gently again for me. Good. Now this angulation is quite steep, so I might have to actually adjust her chair, put her down to bring the tube head in order to make it positioned properly. But it's as simple as that. You look through the ring, you can see the tooth centered on the bite block, and we'll capture a great cuspid view. Open for me. Thank you, ma'am. Very good. The resultant image shows a nicely centered canine with minor overlap between the first bie and the canine distal surface. And we can see a small fibrous healing defect where the lateral incisor has had endodontic treatment and some surgical treatment because of the failure of the endodontics. This is a nicely centered canine view. As we move posterior, the first view is the maxillary premolar, and again you can see that our image receptor in the middle of the palate is far enough anterior to capture the distal half of the canine. Here is a short video of the maxillary premolar view. Next we're going to move to the posterior views, and when I picked this rod up, I had assembled it. It actually has just one right angled turn. I again inserted my bite block in there, put the ring on. When I look at this rod, however, it does not look like it's going to fit in her mouth. This particular part of the rod will end up impinging on her soft tissues. So I know I've assembled it incorrectly for the upper right side. Now, this could be used for the lower right side because the tissues would actually fit in this portion here, so I could use it on the lower right. The easiest way to actually switch this, because this would be for the lower right and the patient's upper left, the easiest way to switch this for the upper right and lower left is to hold the instrument away from you. Take the ring, pull it off the front, and turn it a half turn, and insert it back. Then take this particular bite block, pull it off, turn it a half turn downward, and insert. When I do that, now the tissues can fit in this particular space very comfortably. Okay, Shannon, we're going to do the posteriors. And the first one is the premolar periapical view. We're going to put our dot in the slot. In this particular case, we want this anterior edge of the film to capture the distal half of the upper canine. So if you would open big for me, first I'm going to eyeball where that is. I want to see in her palate about where I want to be with the instrument. And when you place these, you have to angle the instrument in order to get it in. You can very rarely put it straight in. People don't open that wide. So I'm angling the instrument. I get it into her mouth gently. I pull the tissues out of the way, and I get it up onto the teeth that I'm going to radiograph. Just close gently. I take a quick peek as she's closing. Just open again for me. And I can see that my film was far enough anterior. I also saw that we need that cotton roll again. So we're going to get that cotton roll. Keep it handy in our right hand. You open big for me. Okay, and I can see exactly where I need to put it to balance it. Close gently. Good. Is that comfortable?
Mm-hmm.
Okay. And if I do one quick peek, I can just retract her tissue a little bit. I can see that the anterior edge of my film comes far enough to capture that upper canine, the distal half at least. Again, I would bring my instrument or my tube head in, position it, parallel the cone with this rod, and I would capture a very good image of the premolar, including the distal half of the canine. Thank you. The resultant image, which we saw earlier on in this program, shows a perfectly placed periapical view of the maxillary cuspid. The small amount of overlap between the second premolar and first molar is actually due to positioning of the tooth in the arch, since all the other contacts are open. So again, this is not the fault of the dental assistant, but another bite wing might have to be taken, or another periapical, to open the contact properly for interpretation for dental caries. Next, in the last view, we move to the maxillary molar view. Here you can see we've centered the second molar. We're also working again out in the middle of the palate. This is a short video of the maxillary molar region image acquisition. All right, we're going to proceed to the posterior molar view now. And if you remember, in our particular discussion earlier, we talked about centering the second molar for each of these. Do you have your third molars? Did you have your wisdom teeth removed?
No.
No, so they're still there.
They're impacted.
Oh, they're impacted. Oh, lucky us. This patient knows that sometimes they don't. So we're going to assume that they're there anyway, impacted or not. I would have checked. Can you tip back into the headrest again? I don't see a third molar present, but what I want to do is center the second molar. Okay, we're going to do that. Can you open big for me again? And just turn that way towards Dr. Shelley. Now I'm going to put this a little bit further back, and I'm going to still work out on the end of the bite block. I'm getting real close to the second molar here. Now can you close gently for me and go ahead and bite? Good. She did that very, very well. You can see my instrument's quite a bit further back. Breathe through your mouth for me while we're doing this, because I'm going to be talking a little bit. And if she breathes through her mouth, she will not gag as easily. Again, I would bring my instrument in, I keep calling the X-ray tube the instrument. Bring my tube head in and parallel this bar. You open big for me? I angle it to tip it out again, and would take a nice, comfortable molar view. Here is the resultant view. Note that the second molar is centered on the bite block, and if a third molar were present, then we would have captured all of this molar region as well. Now that we've completed the maxillary views, let's move to the mandible. Here we have one less view, since we do not take a separate lateral incisor view. So we must center the central incisors, center the cuspid, include the distal half of the cuspid on the premolar view, including the premolar bite wing view, and center the second molar. This is the area of coverage for the center of the central incisors. You can see the bite block has been used to gently tease the tongue out of the way. Here is a short video of the mandibular central incisor views. Okay, now we're going to do the lower central incisor view and the single cuspid view. And the only reason we're just showing you one side in this particular demonstration, but we really only need 3 films to cover the lower anteriors, a central view and 2 canine views, because of the narrowness of the arch and the smallness of the tooth size. We're using the same instrument that we used in the maxillary anterior view. We're placing the dot in the slot again. It's important here that you do work out on the bite block, and you keep the instrument tipped to slowly rotate, and you instruct your patient to slowly close. Because if you put it in and straighten it up and push it down, it'll be uncomfortable. So we don't want it to be uncomfortable, do we, Shannon? Okay, can you open big for me? Okay, I'm going to place it way back in the mouth, and I've gently placed her tongue out of the way. And it's not on the teeth of interest, but I'm going to say to you, slowly close. And as she slowly closes, you can see that she relaxed, and those went into place very, very easily. I'm looking to see if the central incisors are centered, which they are. Stay biting on that for me. I move the ring up. We would bring the instrument in, and this would, or the tube head rather, and this would be a very nice angle to get that central incisor view. Great, Shannon, can you open for me? Good job. Okay, have a good swallow. If performed correctly, we get all 4 of the incisors, centrals and laterals, with all of the apices visible. Of course, they don't come numbered or with arrows to help us out, but you get the idea. In moving to the mandibular cuspid view, this is the first time I'd like to introduce the concept of the sort of slowly rotating the actual bite block into place. Too many times the operator wants to get this view and the premolar periapical view parallel right from the beginning. It's much easier to keep the instrument sort of at an angle hovering above the tooth or gently resting on the tooth of interest, and asking the patient to slowly close while rotating the bite block and instrument into place. This way you're not forcing the image receptor into the floor of the mouth, having the patient resist and having the patient be uncomfortable. This is a short video demonstrating the capture of the canine, including the rotating sort of technique. We would switch our film out, we would come to the cuspid view. Now you remember, go ahead and tip back into there again. The cuspids often have a pointy area. She's got a couple little tori that are kind of poking out into the floor of her mouth a little bit, so I have to navigate around that, and I'll want to go across the arch for that. So let's do that one more time, and I think we may need our infamous cotton roll again, so let's just see. Can you open for me? Okay, and you can see I'm nowhere near the tooth surface, just sort of angled. Can you start to close gently for me, Shannon? Good. And then bite. Is that impinging at all? Not too bad. Then I won't use the cotton roll. It's comfortable. The canine is centered. I could look through the bottom, bring my X-ray tube head in, and take that view. So if you can trust the instrument, it'll do all the work for you. Can you open big for me again? Good. Helps to have a good patient too that does follows all the instructions well. Excellent. If we do this correctly, we'll see the tooth of interest. Here, the mandibular canine is perfectly centered. In the mandibular premolar view, it is very important to use this premolar sort of rotating technique. We know that the floor of the mouth is shallow in the anterior region, and if we try and force the instrument down into the floor of the mouth to parallel from the beginning, the patient will resist. So we keep the angle as we enter the mouth, hover the bite block over the region of interest, making sure we capture the distal half of the canine, and then we ask the patient to slowly close, and as they do so, rotate the instrument into place. This will result in a far more comfortable image acquisition. Here is a short video demonstrating the mandibular premolar periapical view, including the rotating technique. Now, you remember that when we did the posterior view, we had a ring and rod arrangement, 2 right angles on the ring, or on the rod rather. We place the ring on and we take the bite block, and it doesn't really matter if you get it right the first time. I'm just going to put it on the end, and if I were doing the lower right, you can see that I've got the correct position here. If I didn't, again, I would face it away from me, turn this ring once, a half turn down, take this particular bite block and turn it half a turn down. Okay, so we're going to do the lower right. And this is another critical area because if you open for me, Shannon, the floor of her mouth curves gently upward in the anterior region, so it's quite shallow. She has a torus that I have to negotiate around. I have very narrow space, which maybe we'll show you later on this particular film, and I have to kind of negotiate my film into place there. So this is very important to then instruct your patient to slowly close. Open big for me. We'll tip it till we get it in place. I'm across the arch. I can capture the canine. Can you slowly close for me? And you can see I rotate the instrument into place. That's probably pinching a little bit because she's shallow there. But it's comfortable enough for me to get the tube head, bring it over, position it, walk out of the room, make the exposure, come back. Can you open big for me? And quickly take it out. You okay? Mm-hmm. Didn't scratch you too much in the bottom?
Not too bad.
She wouldn't tell you anyway, so okay, all right. The resultant image shows a great position for the premolar periapical view, identifying all of the distal half of the canine and the apices of the canine, premolars, and even most of the first molar in this view. This is a close-up of the same image. Note the minor overlap between the 2 bicuspids, again with the other contacts open. This means that the second bicuspid or first bicuspid is a little ectopic to the arch, either buccal or lingual. So this results in the overlapped contact. We would have to correct this by picking a different horizontal angulation to, quote, open that contact. Finally, the mandibular molar view. Again, I can't stress enough how important it is to center the second molar. Here you can probably get the film or image receptor down into place a little more easily than the premolar view, since there is more depth in the floor of the mouth in this region. This is a short video of that technique. Now we would change out our film, and we're going to do the posterior view. And even my patient can tell me now what the important part is for this. What do I have to center that I told we did on the top? Center the second molar. She forgot, but we'll. Okay, can you open big for me? We're going to make you into a dentist at some point. I keep the angle. I'm hovering over the second molar. Start to close gently, and then I tip it up. And that's more comfortable than the front one. I'll bet, is it? You don't have to say that. But okay. We make our exposure. Come around. Open big for me. Tip the instrument and angle it out comfortably. The resultant image, which you've seen many times in this presentation, is a perfectly centered second molar and the capture of the third molar, or wisdom tooth, including the severely curved distal apex. Finally, we're going to move to patient management concepts and just reiterate some of the things we've just talked about in this particular video. We want you to work on the end of the bite block. In this diagram, we've actually come too far anterior, and you can see that the film was bent against the patient's palate. This would be uncomfortable for the patient and could lead to some distortion or some elongation of the apex in that region. In this illustration, the operator is too anxious to get parallel and will probably push the receptor further down into the patient's mouth. This will cause the image receptor to impinge on the floor, and the patient will resist because they are uncomfortable. They may move or open, resulting in the loss of the apical region information. So we would like you to work out on the end of the bite block and slowly rotate the instrument into place, asking the patient to slowly close. We keep the angle as we enter the mouth. We ask them to slowly close, and we tip or rotate the instrument into place as the patient closes. This tip, of course, was demonstrated in the video of the mandibular cuspid and premolar views previously. In summary, I'd like to remind you of the four concepts. We want to center the tooth of interest. We want to capture the distal half of the canine in the premolar periapical views and the premolar bite wing view. We want to center the second molar to capture all of the third molar region. And we want to move about a tooth and a half in the bite wing views in order to maximize the contact or interproximal contact information. I hope that this segment and these tips will help you take better radiographs that are more diagnostic. Thank you.